Oh, I couldn't find my key. I was panicking. All right, good morning, guys. Over the weekend, you guys had 2 chapters of homework. Chapter 5, which was on dementia, and Chapter 6, which is a skills chapter. I want to talk to you just a few minutes about dementia. There's 2 things that you need to kind of understand. That the book does a pretty good job with dementia, but there's a couple things that I think that we need to maybe expand on a little bit. The term dementia doesn't really mean anything other than there's something wrong with the brain. It's a very generic term. It's like me sitting here and saying, I'm sick today. Well, that just means that I'm not well, but it doesn't really give you any specifics. It doesn't tell you whether I've got a head cold, whether I've got a sore throat, whether it's a stomach issue, whether I'm achy, or if I have an earache, right? Just sick just means not well, but it's very unspecific. Make sense? Well, that's the term dementia. Dementia is just brain sick. It doesn't give us specifics. So when you hear that term dementia, a lot of people automatically assume Alzheimer's. Well, Alzheimer's is a kind of dementia. It's more specific, but not all dementia is Alzheimer's. Does that make sense? Dementia just means brain sick. Alzheimer's means, okay, the stuff that holds all of those neurons together got all gummy. And now the neurons can't really communicate with each other. So let me explain to you why that matters and why a lot of our Alzheimer's patients have difficulty with recalling family members. Okay. So in order to understand this, we have to understand a little bit about how the brain works. And I'm not going to get into like biochemistry and all of that. I'm really going to simplify this down into 5th grade analogy. Okay. Your brain is a memory making factory. It's one of the things that it does. Does a whole bunch of other things, but it's got a specific department that's geared toward making memories. It's what it does, okay? Now, those memories aren't orderly. They're not like packaged together and filed in a filing cabinet somewhere that you can pull out and go, okay, this is a complete memory. A memory is built up of a lot of different sights and sounds and smells and colors and emotions. And all of those are stored in different filing cabinets. So when you're trying to recover a memory, right? So if you're trying to recall something, your brain is going to go over here and pick up the smell, and over here and pick up the color, and over here and pick up some other part of it. And then it constructs that memory. Does that make sense? Well, if we have a condition where the neurons aren't really talking to one another, it's really hard to get all of those pieces together to create a memory. Make sense? So because your brain is a memory-making factory, we kind of have to talk about the factory part of this. So if I were to develop a pen, let's say that I invent this thing and I go tour some factories and I'm trying to decide which factory is going to make my pen. The first one that I tour is brand new, state-of-the-art, just built. Everything is computerized and electronic and high quality and super efficient. Every pen that comes off of that assembly line is going to be high quality, work like it should, and it's going to work super fast. Good? Now, the next factory I tour is 80 years old. Obsolete technology. The gears are rusty. The springs are broken. The conveyor belt only works half the time, right? It's not going to produce a high quality pen. In fact, some days it's just not going to work at all. It's just having one of those days where it's all buggy. Make sense? Which one of those factories do I want to produce my pen? State of the art, because it's going to be the most consistent and have the highest quality. Does that make sense? Good morning. So if your brain is a memory-making factory, we can put this analogy to work. So when our factory that makes our memories is brand new, state of the art, everything is working as it's supposed to, that's going to produce the highest quality memories, right? Memories that are going to stick around for a very long time because they're good quality. But that same factory 80 years later is no longer state of the art. It's no longer working at peak performance. So there's going to be days where that factory doesn't make any memories at all. It's just totally offline. Or there's going to be days that that factory makes some memories, but like certain pieces of it are missing. It's just not complete. Your brain ages with you. And since your brain is a factory, that factory ages with you. So when we have a patient with dementia, just that umbrella brain sick term, that just means the brain is not working well. It's not doing what it was supposed to do or what it did back when it was new. Something is just not working well with it. Alzheimer's is a very specific type of that, where the memories aren't able to be reassembled. So this is why you can have a patient with dementia who remembers the shoes they wore to a piano recital when they were 12 years old, but has no idea that they just got back from lunch, because the memory of lunch wasn't made by that factory that day. Okay, the factory's offline. But the factory that made that piano recital memory, that factory that made the memory was good quality. Therefore, the memory is good quality. Make sense? Now, that's dementia. That's just kind of how dementia works in a general way. Alzheimer's is very specific. It takes it a step further. Not only does the brain not produce the memories as it gets older, but it has difficulty pulling together the pieces of the memories that were made previously. This is why your Alzheimer's patients often don't recognize their family members, because it can't pull those pieces. The memories are there. The components of the memories are there, but they can't reassemble them into anything meaningful. This is also, it's very frustrating for family members. How can you not remember me, Mom? I'm your daughter. It's very frustrating for family members because they don't understand that it's not a willful forgetting. It's that the brain just can't put together all of those pieces and reassemble the memory. What often happens, though, and this is very interesting, is that grandchildren are often recognized as children. And the reason for that is because if the brain is able to reassemble some of those pieces, it's doing it with those higher quality memories from years and years ago. That's what it's trying to reassemble. So you probably look like your parent did at that age, and that is how the brain is reassembling that information. Isn't that interesting? So the brain just has no memory. The mechanism there, it has no memory of a child as an adult. That brain didn't store that information, can't recall that information. That just doesn't compute. Good. So when we're working with dementia patients, we need to understand that this is not willful. This is not, and I'll give you a good example. Patients with dementia, if you're working in a dementia unit, and most of our dementia patients are Alzheimer's patients, but that's not the only kind. But if you're working in a dementia unit, you will often have to repeat the same thing over and over and over. When's lunch? Lunch is at 11:30. When's lunch? Lunch is at 11:30. When's lunch? I already told you when lunch was. It's not willful. They're asking when lunch is because your answer is not penetrating. It's not getting stored. Their memory is totally offline today. So you can tell them anything in the world. They're not going to remember it because that factory is not working. So they'll ask you when's lunch, and 5 minutes later, they're going to ask you when's lunch because they have no idea that they just asked you when's lunch. So we have to use a lot of patience with these patients. But sometimes your patients will start to fixate on things. And the most common thing that they're going to fixate on is, I want to go home. This isn't home. When am I going home? Because in their mind, they're recalling a home from years past full of people that don't exist in that form anymore. And anything that you introduce is not going to meet that expectation. Does that make sense? So your older patients often get fixated on, this is not right. I should not be here. I should be home. And they will fixate on that. And a lot of them will actually try to leave the facility. We call that elopement. So if you have a patient who's fixating, who is hanging out by exits, who seems to be very anxious, especially if it's kind of a sudden anxiety, they are at risk for elopement. We've got to really watch those patients because they'll slip out of a door before you even realize it. So you really want to get them involved in an activity. We want to get their mind off of what they're fixating on. Let's go for a walk. Let's, put a puzzle together. Let's do something so that you're not just sitting here fixating on this and then trying to leave to seek that out. It doesn't exist any longer. Does that make sense? Good. So if you have, this is the biggest thing I need you to take away. First of all, you need to be patient, answer the same question as many times as it takes, redirect them into an activity. That's usually much better because if they're asking the same question, they're fixated. But they might also be trying to tell you, I'm hungry. That's how they're trying to express that information. I'm hungry. If they're asking, when's lunch? When's lunch? When's lunch? They might be hungry. Give them a little snack. Okay. But the biggest thing I need you to understand is that agitation and sudden confusion and, some behaviors that might indicate their anxiety is ramping up, please protect those patients. They're probably exit seeking because they're afraid. So watch them closely, redirect, involve in an activity. Make sense? That's the big thing that I need you to understand out of chapter 5. Sometimes your dementia patients will really surprise you, though. We had a patient that was in a 3rd floor dementia unit. He would take apart wheelchairs, and he always left the pieces like right in front of the elevator. I don't know why. Nobody knows why. But he would take apart wheelchairs and just leave the pieces there. So when you got out of the elevator, if you weren't watching, you'd trip over the pieces of the wheelchair. He would take the knives from the dining room. He'd always slip a knife into his pocket and use it as a screwdriver. And staff just got really frustrated with them, started giving them plastic silverware and, all these things to try to stop the behavior. Me, I'm always interested in the why. Why is this behavior happening in the first place, right? Staff's trying to stop it. I'm like, why? Why is it happening? So when his nephew came and visited, I asked, what did he do for a living? And he said, oh, he was an engineer. He actually worked at NASA, and he worked on one of the Apollo missions. And so that's where his mind was currently centered. So he was trying to work out some sort of a problem, some sort of an engineering problem in his mind. And what do engineers do? They take things apart and they put them together. And that's, what he was exhibiting was a reflection of who he was. You're not going to stop that, right? Giving him a plastic utensil is not going to stop that drive. So my recommendation was, let's get him a set of Connects, which are like little, they're engineering toys where you can put things together. And you got him a set of Connects, set him up at a table, and he was just a happy little clam from that point. Quit taking the wheelchairs apart. So sometimes in order to solve the problem, you kind of have to find out a little bit more about the patient. Does that make sense? Good. Getting mad at him for doing that served no purpose. That was wasted time. Let's see how we can work with him rather than against him. Make sense? All right. So let's see how you did on chapters 5 and 6. If you did not get to it, just say pass. Victoria. Thank you. Tempest. Jaylind.
I got 2 wrong on chapter 5 and then 1 wrong on 6.
Very good. Thank you. Serena. Brigitte. Monica. Kaya.
I did it chapter 4, so I did it this time.
Okay.
So I got 85 on that one.
Thank you.
Chapter 5, 90, and then 100 on chapter 6.
Beautiful. Thank you. Arjola.
I had 2 wrong on chapter 5 and 2 wrong on 6.
Thank you. Ito. Bobby.
90 and then 95.
Thank you. Jayothi. Deja. Okay. All right. Any questions on those questions? Anything you need me to explain to you? Good morning. That's okay. Anything you need me to explain on chapters 5 or 6? All right, we're going to jump into a brief review, and I really am going to go through this quickly because I keep getting stuck. Class is half over. If you have not registered for test yet, you probably should make that a priority. That way you're testing about a week or 2 after graduation, which is perfect timing. If you wait too long, unfortunately, what ends up happening is life gets in the way. And you start to think, well, I'll register after I practice a little bit because it's been a couple weeks since class, and then you don't practice, and then a month goes by and you're like, oh my gosh, now I'm don't know if I remember everything, so I'm going to review first and then I'll register, and you just keep putting it off, and eventually you don't test. And I don't want to see that for you. I want to make sure that you're meeting your goals. So if you have not registered for the test yet, make that a priority. Our students do very well. You will be fine on the test. Yeah, no, register now. Register now. Game show tomorrow, 11 a.m. on my YouTube channel. And I got to sit down this afternoon and think this out. I may be introducing the format for the practice test. I got it done 2 o'clock this morning. I got it done. So Jake, can you hand it to me real quick? He's going through it now. He's my beta tester. Make sure there's no typos. So this is it. It's 55 pages. This is it. There's about 300 questions in here, and it's guided. This is the quick reference that goes with it. Once you have completed this, this is all you need. This answers every single question that you will find. Every question. This right here will give you the answer for. Isn't that crazy? That you can answer the written test with 1 sheet of paper. You have to understand this for this to work, though, right? They go together. So he's reviewing it now. And then I'll be ordering, or I'll be putting it up on the website, and I'll give you guys the link for it. You guys will all be able to go through this for free for a review. I will be selling it on the website, I think probably $10 or something. But this isn't a practice test in the traditional sense. Practice tests just give you a bunch of questions. You go through it, you get them right, you get them wrong, maybe some rationale in there. But practice tests only show you what you know. They don't really teach you well. This actually teaches you how to look at the question, how to evaluate it, how to look at the answers. Every type of question has a specific type of answer that goes with it. For instance, if you see in the question the word assigned, if you see assigned or instructed, That is a follow the care plan question. You were assigned to give foot care on Monday. Your patient's in an activity. What should you do? A, pull them out of the activity. B, perform foot care at the activity. C, perform foot care after the activity. Or D, perform foot care on Tuesday. Yeah, we're going to follow the care plan. So you can disregard all answers that don't follow the care plan, right? So we're going to perform foot care as assigned. It says on Monday, there's no time associated with it, so you don't want to interrupt your patient. So we're going to follow the care plan. So if you see that word assigned, you look for the answer that follows the care plan. That's it. So you've just answered 10 questions off of the state exam. If the word assigned or instructed is in the question, it's a follow the care plan question. If you see the name of a skill in the question, like foot care, well, if assigned isn't there, right? So that's the first thing we look for is assigned. So we keep going if assigned isn't in there. If you see the name of a skill like dressing or feeding or foot care or pericare, it's probably a step question. It's going to ask you about a step. What do you need to remember? What supplies do you need? What's the order? So you would need to know how to do the skills to answer those. That's what they're asking. If it's a safety question, you pick the answer that keeps the patient safe. Safety requires action. Notify the nurse is not an answer for a safety question. Safety requires action, not notify the nurse. So do you see how you can just figure out what the question is asking and then apply a rule and it gives you the answer? That's what this does. And it does it step by step. So I explain the rule. I give you 3 questions to show you how the rule is applied. I explain them all that way. And then there's 10 questions per rule. So you can see all of the correlations. You can see it on the page because I bold the questions. So you can see it. Then we do a 30-question practice test. Then you do a 30-question identify the category to help you make that association. Then you do that same one with the answers and then 2 full practice tests to put all of that knowledge to work. So all of that is in here. And I'm going to try to get it to you by Friday. Here you go, Jake. I'm going to try to get it to you by Wednesday. Give you the link by Wednesday to go through it so you can give me feedback before, you'll have a week to give me feedback before graduation. Okay, good. But wouldn't it be nice to go into the written test being able to identify the question like that and know exactly what the right answer is? This took me a while to create because the first 2 trials that I did with it, it's called the CNA FACTS, F-A-C-T-S. So trying to line those up in the right way to cover every type of question. I always had a group of questions that were kind of not in the right category. So I really had to go back to the drawing board several times with this. So I finally got it done. I stress tested. It seems to be good. So that's why I'm really excited about getting your input. But I think I'm going to be introducing this in the game show tomorrow. And I'll be going over the question and the category. So I'll be explaining what the category is, why the category is that way, and why the wrong answers are wrong. So tomorrow, if I do that, if I can get all that set, tomorrow's game show will be just a little bit longer than my standard game shows because I'm going to be giving a little bit more exposition and teaching. So those of you who are going to join 11 a.m. on my YouTube channel, it's 4YourCNA, and it'll probably be closer to an hour tomorrow. See if I can get my stuff together. All right, so skill rules. We follow the care plan, the whole care plan, and nothing but the care plan. We observe for abnormalities, and we report those to the nurse. This is the category, follow the care plan on the state exam. Every skill that you do starts with an opening. Every opening starts with a knock. We greet our resident. We address them by name. We introduce ourselves by name and title, and then we tell them what we're there to do. We get permission, close curtain, wash hands, get supplies. Cardinal rule here is do not touch the patient until your hands are clean. Very good. When we're talking about supplies, we have to talk about gloves. You're not going to wear gloves for everything, but you are going to wear them if you're possibly going to touch body fluids, personal skin, or non-intact skin. If you do decide to wear them, the first thing those gloves should touch is the patient. Keep your gloves clean for your patient. Once you've touched the patient or the environment, they're soiled. So don't touch a lot of stuff. Don't spread those cooties around. Try to pay attention to what you're touching with soiled gloves and then remove those soiled gloves correctly. Anybody watch any medical dramas on TV?
Oh my God, I was just thinking that.
Yeah, if you watch any medical dramas, you'll pick this up real quick. Yeah, you're going to be like, why are you touching the curtain with those gloves? You'll start screaming at the TV. Yes. Oh, I love the pit. You'll start screaming at the TV like, what are you thinking? But it will make you aware that everything in that patient environment is not as clean as you think it is, because staff members violate this rule all the time. So kind of keep that in mind in a real clinical setting. Remember, we're there to keep our patients safe. So think about that. All right. If we're going to use any other types of supplies, we need a clean place to put them, and that's what our barrier is for. Barrier provides a clean place for those clean supplies. You only touch supplies with your clean hands, and we don't hold them up next to your uniform. For best results, go get the barrier first, then get your supplies and put them on the barrier. One of the supplies you might need is a privacy blanket. We use a privacy blanket anytime the patient is uncovered or undressed. We use it for privacy and for warmth. It's not just for privacy, it's also for warmth as well. Put it on over the sheet, don't snap it or shake it, and pull that sheet down underneath. At the end of the skill, take your gloves off before you take the blanket off. Another type of supply that we use quite often are linens, and they have special rules. Most of these are repeated. Don't let the linens touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. Clean rolls toward you, dirty rolls away. This is how we put anything under our patient. And don't put anything on the floor but feet or shoes. Don't put anything on the floor but shoes. So don't put clean linens on the floor. Don't put dirty linens on the floor. And anything you take and don't use, you must discard. When it comes to the patient, the safest place for them is in the middle of the bed. If we have to turn them on their side for any reason, you want them in the middle of the bed after the turn. You can't rely on side rails to keep your patient safe. Not all places have side rails. And even still, if you don't keep the patient in the middle of the bed, if you just roll them and they're right up against a side rail, that's not comfortable. So in order to make sure our patient's in the middle of the bed after the turn, we scoot them toward us first and then roll them away from us. We remain behind, the patient's behind. But the patient must always be in the middle of the bed. Okay, this is a very common skills question that you would have on the written exam. Patients must always be in the middle of the bed. We have a lot of washing skills that we do, a lot of washing skills. And when we're doing these washing skills, we have to remember that we don't put soap in the basin. We need that water clean. So basins are no soap zones. We're going to use a paper towel to get water. We'll check it. Your patient will check it. It should feel warm, not hot, not cold, just warm. We apply soap to the washcloth, not in the water, because whatever we wash, we rinse. Whatever we rinse, we dry. Okay. By the way, I don't have it up here, but no drippy wet washcloths. Make sure you're wringing those washcloths out really well before you put the soap on them. No drippy wet washcloths, because we don't want our surface to get wet, whether it's the table or the floor or the bed. We don't want our surface to get wet. If you're going to put lotion on, we warm it up and then we wipe off the excess. Basins are cleaned the same way. Rinse it, dry it, store it. That's all they care about for the test. But use a paper towel between your dirty hands and the drawer, right? We don't want to overly contaminate that drawer. We finish every skill the same way with the closing. The first couple, we don't care what order you do them in, but make sure the patient's in a clean environment, bed is in the low position, ask them if they're comfortable, address preferences. So offer them a magazine. Open the curtain, give them the call light, make sure they're covered, no knobby knees. Once you've done all of those things, then you're going to go clean your hands. So we're done with the patient. We're done touching their cuties. We're going to go clean those cuties off our hands. And then if you have to chart or document, you do that after hand washing. And then our cardinal rule here is to end skill with clean hands. So what is the last thing we do? Wash our hands. Okay, good. Good. All right, pulse. We learned how to take pulse, normals between 60 and 100. Radial pulse is located at the top side of the wrist, at the thumb, where the thumb joins the wrist, at the bendy part, not way up here. 2 fingers, fingertips, not flat part, never thumb. 2 fingers, thumb on the back. You're going to count for as long as the care plan tells you to, which for the test is 1 full minute. And for the test, you're going to say start when you start counting, stop when you stop counting, so the evaluators can play along because they're going to be on the other side counting the pulse as well. In Florida, you have to count with 2 evaluators. So you'll have to write down the first number before you count with the second. They don't make you remember it. It's okay. And then you're going to do your closing and document that second reading. You can be off by 4 beats in either direction.
So, not to be anal, but you're telling them you're going to start, like say, right now I'm going to start when the second hand gets to 3. I'm saying start and then count.
Right.
Like that's nerve wracking.
Yep. Just pick it.
Why can't we just say I'm going to start when it's got 3 and then go?
You can do that. That's fine. You can do that. You can say I'm going to start on the 3.
Okay. Cool.
That's fine. That's fine. But you can also just say start out loud when you start counting. Either way.
So basically what they do is one of the evaluators goes and checks the pulse, and then afterwards I would go, and then the other one checks the pulse and then I would go.
No. So you're on one side of the patient. I'm over here holding this hand. Evaluator number 1 is on the other side holding that hand. And you say start or pick a starting point. You know, you let them know when you're going to start, right? And you're both counting at the same time. So because you're both counting at the same time, theoretically, you should get pretty close to the same number because the wave that we're counting is being produced by the heart. It goes throughout the body. So somebody on one side is counting the same waves that somebody on the other side is. Okay? So you're going to do, because it has to be at the wrist, right? There's only 2 wrists. So you're on one side, evaluator number 1 is on the other side. You say start, you count for 60 seconds, you say stop. The evaluator at that point, they don't expect you to know all this. Okay, I'm giving you insider information. At that point, the evaluator is going to tell you, I need you to count with me as well. Evaluator number 2. So same thing. Now, they're going to, normally you would do your closing, wash your hands, document, wash your hands again, right? That's how we normally do it. In a clinical setting, you're not counting with anybody, so that's exactly how you're going to do it. But for the test, because you have to count with a second person, that's just for the test, they're going to let you write down that first reading so you don't have to try to remember it while you're counting reading number 2. You don't have to. Nope. They're kind of breaking the test. Okay, because how do I explain this? Okay, so the test is supposed to simulate real world conditions. All right, it's not supposed to be structured as a test. It's supposed to simulate real world. So for me, I want you to do your closing, wash your hands, and document because that is real world conditions. And then do the thing again with evaluator number 2. That's what I want. Of course, I want you to wash your hands before and after every skill, right? because that's real world conditions. Because otherwise what's going to happen is you're going to get out there and you're going to think, well, it was okay to simulate during the test. So I'm just going to skip a couple of hand washings to make my day go faster out here, right? They're not reinforcing that principle. I don't like that. I think it sends the wrong signal. I think it sets a precedent that doesn't need to be set. But where do those evaluators want to be? Yeah, so they don't want to watch you wash your hands 6 times. They don't want you to do your closing and then your opening again. They want to go home. So they're letting you shortcut this for their own comfort, convenient. That's the word I was looking for, convenience. So they're letting you shortcut this. I don't like it personally. I don't like it. They're going to give you instructions. Just listen to their instructions. You don't have, I'm giving you kind of insider information so it doesn't blindside you, but don't get caught up in the mechanics of this. They're going to tell, because they're breaking the test. They're breaking the test. I don't like the fact that, because it's confusing for students. They're breaking the test. As long as they have told you that you can simulate hand washing, yes. Yeah, we don't simulate until they tell us to. But once they tell us to, you can simulate for all of it. Yeah. And yeah, I would, for the first hand, or first, I'd wash my hands before I document it. Just so that they know that you know that that's important. All right. Dressing a resident with a weak arm. Privacy counts on this one. We're going to close the curtain and use a privacy blanket and get their clothes before we undress them. Those are all important. Patients have the right to choose their own clothing, so make sure that you ask them. Anytime we lift an extremity, we lift it from below with a flat palm, never from above. From below, support the extremities, and we undress the strong arm first, and then dress the weak arm first. Pants and socks are just pants and socks. Put them on, make sure they're on right, okay? At the end of the skill, make sure your patient looks good. Toe seams along the toes, pants over the hips, and tag in the back. I have to stress that because that's becoming an issue. People are putting the pants on backwards. Do you know how uncomfortable it would be to go through your day with your pants on backwards? Right? Pants are kind of made a certain way because we're not the same in the front as we are in the back, right? So make sure you're paying attention to that. Make sure that the buttons and the snaps are fastened appropriately, that they're not just like haphazardly put together. Make sure your patient looks good. That's becoming an issue on the test. I don't know why.
They're in a rush.
They are in a rush. And I think that a lot of people on the test are still very, very, despite me shouting into the void here, they're so focused on themselves. My steps, my test, my performance, me, that they forget that that's not who the test is about. Who's the test about? The patient. That's right. And that's why a lot of what I say is geared to get you out of your own head and into looking at that patient. If you can do that, this test becomes super simple, guys. Because a lot of these steps that I'm telling you are mechanics that if you're in your head, you have to know this. But if you're looking at the patient, it just makes sense. Like, well, yeah, of course you'd have the pants on the right way. I mean, why do you even have to say that? Because if you're in your head, you need that step. Yes.
When we come in after this class is over to practice, who's around to tell us if we're doing it right now? You said
Okay, so great question. All right. So 3 things with that. When you're practicing in here, you should be practicing in groups of 3. So you need to make friends. Okay. So that's the best way to practice is in groups of 3. One person is the patient because most of our skills are done on a live person. There are a few that are mannequin. Yes. Most are done on a live person. But somebody needs to be a patient. Somebody needs to perform the skill. That's the CNA. The third person should have their skills book in front of them and should be reading and prompting the CNA if they get stuck. Okay, the next step says you should be doing this. Okay, but that third person reading as they're watching it being performed, all three people in that scenario are learning. And then you switch. You switch.
And then I started thinking, like, wait a minute, did we just come in by ourselves? And
Yeah, so that's the
with Jake here that's not paying attention to whatever.
So that's the best way of practicing, is making sure that there's three people. So one person's the patient, one person's the CNA, and one person is the monitor. Now, I can be here and I can prompt you through it, but you're not going to learn anything that way. I'm just telling you what to do at that point. You're following directions. What you need to do is work on learning the steps, and every person in that scenario learns. Okay. Now, if there's only two of you, what do you do then? Well, the patient becomes the monitor. The patient has a book and is reading along. So, yes, yeah, you will be hopefully today, if I can move along. That's not about you. That's me. That's all me, because I get off track. But yes, hopefully today you'll have some practice time. You'll definitely have practice time on Wednesday. And then next week you'll have practice time in class as well. So yes, you will. So two people, the patient becomes the monitor. Three people is ideal, best way to practice. But you also have Jake here. And if you want to review the video, Jake has this system set up all the time. So if you want to review the video, just tell him, hey, Jake, I want to see the video. He'll plug it in for you and you can watch the video. You can actually have him pause the video. You know, I do a step, pause it, you do the step. He plays. I do the step, pause it, you do the step. Okay, so he can help you with that. He runs all the tech. He can also answer general questions, but he absolutely will pick up the phone and call me and say, okay, hey, somebody's got a question about this. Is this okay? And I'm always available by phone on those days. Okay. So even though I'm not physically here, and sometimes I do stop in, but even though I'm not physically here, you don't need me. And that's kind of the point. You don't want to be relying on me at that point. Okay. Because if you're still relying on me during open practice, you're not ready for the test. Okay. That practice time is all about building your confidence. If I'm here, if I'm your crutch, it's hard for you to build that confidence. Does that make sense? Good. All right. Okay. So dirty clothes go in the hamper. Adjust the clothing for neatness and appearance. Call light goes in the stronger hand on this one. Hand and nail care. This is a mini mani. We're going to soak the hand, take it out and put it on a towel to wash it. Remember, we wring out the washcloths, put the soap on the washcloth. Wash all surfaces. Put it in the basin to rinse. Put it back on the towel to dry. Then you're going to clean under the nails with the slanted end of the orange stick, wiping it off in between each nail. And then you're going to file in one direction toward the middle, not back and forth rapidly, just one direction toward the middle. Then warm up the lotion, apply it, wipe off the excess, and clean up. Mini mani. I would want this skill if I were being tested. This is a hard one to mess up on. The biggest checkpoint on this skill is making sure the patient checks the water, which we already know with washing rules.
For the filing, I know we saw the video too, but like you'll go one direction and then would you switch?
Yes. Yeah. Always toward the middle. So this way I'm going to go here. This way I'm going to go here. And then I'm probably going to go across the top just to, you know, push that down that point. Okay. All right. When you're testing, your person's nails probably aren't going to be dirty and they're probably not going to be ragged. So you're kind of just hitting the high points, right? You're not going to be really like filing down. Okay. If you have acrylic nails or gel overlays or any sort of a manicure, they try not to use those people for patients for this because they don't want somebody messing up your manicure. Well, we still have to, we can't really simulate. We still have to file at least, you know, we have to go through the steps, but you have to make contact. Yeah. Okay. All right, making an occupied bed. We're changing the bottom sheet a half at a time. The rest of the bed is all pretty much the same, whether it's occupied or not occupied. It's the bottom sheet that matters here because your patient's still in the bed. So we make this a half at a time. And this is where we learned that clean rolls toward me, dirty rolls away memory aid. Okay, so your patient has to be on their side in the middle of the bed to take up less space, less footprint. You're going to take that dirty sheet, roll it toward the patient, tuck it under them. Put the clean sheet on the bed, attach the corners, roll the clean toward you, tuck it under the dirty. Put the patient back on their back, go around to the other side of the bed, put them on their side, do it all again. Take the dirty sheet away, smooth out the clean one. Try to minimize the wrinkles under the patient. Try to minimize wrinkles. Pull that sheet as tight as you can. And then you're going to put the top sheet on, securing the bottom under the mattress, getting the corners off the floor, tucking them underneath the mattress, changing the pillowcase. Pillowcase gets changed last, so we limit the amount of time without the pillow. All right. Side lying position. If your patient can roll on their own, awesome. They can for make occupied bed. You just tell them what to do. They do it. It's like a magic trick. But sometimes your patients can't roll on their own or can't move on their own, and we're responsible for doing that for them. So how do we do that? Well, one of the ways is if you have to scoot them towards you is to do it in segments. Another way is to use a draw sheet. Another way is to use a slide sheet, which is like a slippery sheet underneath them to move them in the bed. There's lots of different ways to get them closer to you before you roll them up on their side. But when you're going to roll them up on their side, proper positioning helps tremendously. Furthest arm up, closest arm crosses, closest knee bent, furthest knee angled. If you get them in that position before you roll them, rolling them, you can almost do with 2 fingers. I mean, they just kind of whoop right there over. Super easy. No stress on them or you because you've already got all of their extremities going in that direction. You're not tangling up all of those limbs. Make sense? Okay. So we always roll a patient away from us. We remain behind, they're behind. So we're going to roll them away from us. We'll put a pillow behind the back and a roll to keep them on their side. Otherwise, gravity is going to pull them back on their back. We're going to put a pillow between the legs, specifically between the knees and the ankles. We don't want those bony areas to rub. That top leg shouldn't be like right on top of the bottom leg, just offset a little bit so you don't have all that weight pressing down, right? Offset a little bit, pillow between. We put a pillow under that top arm just to get it in a neutral position, and then we adjust the pillow under the head to make them comfortable. Hand goes under the pillow, call light goes in the bottom hand. Good? Good. All right. Foot care, just like hand and nail care, a little lower. We're going to put the barrier on the floor, the supplies on the barrier on the floor. We're going to put the foot in the basin to soak, take it out to wash, put it in to rinse, take it out to dry. All of our washing rules apply here. So we use a paper towel to turn the faucet on. We check the water. It should feel warm. The patient checks the water. Try not to get your surface wet. So wring those washcloths out really well. Whatever we wash, we rinse. Whatever we rinse, we dry. Warm your lotion up before you put it on and wipe off the excess. All of that still applies here. So foot in the basin to soak, take it out and put it on a towel to wash. Put it back in the basin to rinse, take it out and put it on the towel to dry. We don't do nails for the feet, but you will look at them. If there's an issue, we're going to report that to the nurse. The nurse has a podiatry list. She puts patient on the list. The podiatrist comes in once a month and takes care of the foot issues. Patient won't get on the list unless you tell the nurse there's a problem, though. Okay. The whole purpose here is to look. So make sure you're saying something during the test. I'm looking at the foot. Put the sock back on. minimize wrinkles, put the shoe back on, and clean up. This skill is easy, but you do have to get on the floor for it. Mouth care, don't overthink it. It's just brushing teeth. Make sure they're sitting up. Towel on the chest, wet your toothbrush, put some toothpaste on it, brush. Whatever they got. Top, bottom, front, back, whatever they got. Let them rinse. Let them spit as much as they need to. If you use a lot of toothpaste, you're going to be rinsing until the cows come home. A little bit of toothpaste is all you need. Let them rinse and spit. Dry their mouth. That step gets missed a lot. And then clean up. Clean your basin, rinse it, dry it, store it, put it away.
I think that we're putting gloves on for this one, and it's like put the toothpaste on and then put the gloves on and then brush it.
Right, because the first thing your gloves should touch is the patient. So if you have gloves on, yeah, so if you have gloves on and you have to put toothpaste on your patient, or on your patient, put toothpaste on the toothbrush, right? If you've got gloves on, now you've got to think, okay, do I want to touch that toothpaste container and then put those gloves in the patient's mouth? It might be okay. It might not. So your safest bet to keep our patients safe is the first thing your gloves should touch is the patient. So do all your prep work first. Get the towel on the chest. Get your toothbrush wet and with toothpaste on it. When you're ready to start the brushing, then put your gloves on. Good. This is going to be hard for a lot of you because, especially if you've done any patient care before, because most people that have done any sort of patient care before put their gloves on almost as soon as they walk in the room. That is a habit you start to get into, but I want you to think about all the things you touch with those gloves before you actually start performing care.
So for most skills, would you say it's all right to go ahead and gather supplies first and then do gloves? Because I've been thinking about this all week and I'm like,
Absolutely. Absolutely. So we're going to do our opening. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do mouth care. Is that okay? I'm going to go close your curtain, wash my hands, get my supplies. So I do. I close the curtain. I go wash my hands. I get my barrier, put it on the table. I get my supplies, put them on the table. I get my toothbrush. I get my water out because there's always a cup of water on the bedside table for you. So I put my toothbrush and my water. I put my toothpaste on it. I put the towel on the patient's chest, making sure they're sitting up. I use paper towel with the bed controller, make sure they're sitting up. And then right before I start to brush the teeth, I put my gloves on. Okay. So everything should be done as far as your prep work before those gloves go on. And like I said, a lot of you are going to struggle with this because you really want to put your gloves on way too early. Yeah, and that's very common. Yeah, the test isn't testing you on that as strongly as I think they should. And the reason is, if you are the patient, if you, knowing what you know now about this environment, if you are the patient, do you want gloves that have touched the bed controller, that have touched the curtain, that have touched the toothpaste, that have touched everything, the drawer, everything else? Do you want those gloves in your mouth?
No, not now that you really are talking about it. No.
Okay. This is how we unwittingly, unknowingly put our patients at risk. Because we're so used to thinking, I need to wear gloves to protect myself. And that's really where that mindset is coming from, right? I want to wear gloves to protect myself. So I'm going to put them on as soon as I walk in that room so that I'm protected. Well, the problem is that, remember, there's only one thing that these gloves can protect. It's either you or the patient. It cannot protect both. Those gloves are it's physically impossible for those gloves to protect both you and the patient. So you got to pick. Who are those gloves really there to protect? Well, you washed your hands before you started the skill, and you're going to go to the sink and wash your hands after you do the skill. But your patient has no other infection control processes other than those gloves. So who do those gloves really need to protect? The patient. That's right. So if you go into the room and you put your gloves on right away and you start touching all of this stuff, you're doing a great job protecting you. Congratulations, gold star. But that hand washing is also protecting you. So you've got all the armor in the world and you've left your patient hanging out to dry. And this is how, unfortunately, patients get secondary infections that kill them. It happens all the time. All the time. We just had a person in their 40s that died from a hospital-acquired infection. In their 40s. We did that. We gave them that. They're not going patient to patient, room to room, getting all up in your, in somebody else's body fluids. We did that. And I would venture to say it probably has something to do with improper glove use. Yep. So we've got to think about gloves just a little bit differently than maybe what our habits in the past have led us to. Does that help you?
Yeah, because every time I look at skills, I'm like, this order is missing to me. That's why I asked you that. So
Very common.
for most skills, not all of them, gather supply, wash hands. gather
All
supply,
skills.
gloves.
All skills.
'Cause when I was,
Well, I'm gonna
I put
back
gloves on
you up
every
real
time
quick.
As soon as I got in your room, yeah.
Wash hands, gather supplies, prep, and then gloves. So I'm going to modify what you said just a little bit because that prep has to go before gloves. Right. Right. The gloves have to be clean for the patient. And I know this is going to be hard for you. This is where the online course, it will really help you. If you're really struggling with this concept, like when do I put my gloves on? The sequencing activities in the online course, the skills lessons, they all have sequencing activities. So you have to put everything in the right order. Everything from do my opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do whatever. Is that okay? Close curtain, wash hands, get supplies. To, put, wet the toothbrush, put toothpaste on it, put the towel on the chest, then apply gloves. I mean, you got to get it in the right order. So that will help you kind of cement in and reinforce those steps. Okay.
I'm imagining just how nervous you are when you're taking the test, and then you're like,
right, and that's
right now it sounds perfectly common sense, whatever. I get it, but when you're actually in the test feeling nervous, I think that's where you'll get like, oh my god, I can put my gloves on.
Right. So there's two things that I've told you and have reiterated over and over again, and I'm not done with you yet. But there's two things that I want front and center in your mind. Number one, your gloves have to be clean for the patient. Number two, the test is always about the patient. If you can cement that in your head, slow yourself down a little bit, think every step with intention behind it, right? Okay, what do I need to do next? And is that about the patient? Does it keep the patient safe? So if you can kind of think it through that way, remember that it's about the patient, not you. It's about the patient. So if you put your gloves on too early and you touch a bunch of stuff, right? And then you go to touch the patient and you realize, oh, wait a minute. Wait, I've got my gloves on. I've touched things. What do you think you could do?
You could say, oh, wait, I put my gloves on too early. I need to change.
Absolutely. Correction. My gloves have touched other things, so I would need to change my gloves. Okay. So before you touch the patient for the first time, take a second, stop yourself. Take a second to figure out, are my gloves clean? Did I touch things? And it just goes back to, what kind of gloves would you want to be touched with? Right? So the test isn't about us. It would only be about you if you were the patient. Right? I'm telling you, if I'm the patient, if I'm the body in the bed, I'll stop you. Don't touch me with those gloves. Look at everything those gloves have touched. Don't touch me with those gloves. Go change your gloves. I'll stop you. But Mrs. McGillicuddy, who's 82 years old, she doesn't. She's not going to be able to stop you. That's who we have to protect. Grandma. Okay? Make sense? My whole class is about protecting Grandma. My whole class. Grandpas too, but you know, especially grandmas. All right. We didn't get to that one. We'll get there. We'll get there. All right, so let's get into range of motion today. So this is going to be on page 80 of your skills book. Go ahead and open your book to page 80. Okay, so if you look on page 80, we have 3 range of motions to learn. They're all the same, just on different body parts. We're going to learn range of motion, hip, knee, and ankle today. We're going to learn range of motion shoulder on Wednesday, and then we'll learn the last one, elbow and wrist, which is a 1-minute skill. I'm not exaggerating, on the following Monday. So these, even though we're a little bit behind on range of motion, they're the shortest skills we have. If you look down here, there's no real principles, nothing new to learn, right? We know skill rules, we know the opening, we know glove rules, and we know the closing. Nothing new to learn there. We are going to learn our skill-specific steps, yes. This is our short version of the skill, which is seriously short. Not very many steps here at all. And down here, you can see that this skill should take somebody with your level of experience, which is none, 4 minutes or less to do. And remember, all these times are generous, right? They're giving you 4 minutes to do this skill, and that's generous. So this is a super short skill. This is going to be done on a live testing student. That person will be positioned in bed at the beginning of the skill, and charting is not required for this skill. So if you look on page 81, you can see our care plan at the top of the page. You can see step-by-step instructions here. No supplies are needed. So this is a super easy one. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your right hip, knee, and ankle, or whatever the care plan tells us to. Is that okay? Close curtain, wash hands. Let's go. Super easy. No supplies. You will not need gloves for this unless there's a reason to need gloves. Your patient for the test, let me go back a page, is another testing student. You guys all planning on showing up in clothes, right? So your patient is fully clothed. Your patient is holding on to all of their own body fluids like a champ. And your patient has no wounds, rashes, sores, or incisions that you're going to be near for the test. So for the test, the patient I just described, do you need gloves for? No. Now, in a clinical setting, if you're doing range of motion and the patient has some sort of a rash or an incision on that side, then yes, you would need gloves. Okay. If you're working on a patient who is incontinent, yes, you would need gloves. Got a stray hair that's driving me nuts. All right. So here's our care plan. Says provide the following range of motion exercise to the resident's right. So which side are we doing? What if we do the left one? We are incorrect. That's right. So it says right. We need to make sure we're on the correct side. Hip, knee, and ankle. It then tells us the exercise that it wants us to do. In this case, there's only one exercise, flexion extension. Now, don't get caught up in the words. I'm going to explain what they mean in a minute, okay? There are 3 possible exercises that CNAs can do. Out of those 3, we're only doing 1. It says to provide 3 repetitions of each exercise. So how many reps are we doing? What if we want to do 10 because we think it's going to do better? Because we have to follow the care plan. Are you starting to see that this is pretty easy? You get a list of instructions, you just do that, and you pass.
So the 3 is just like 3, not 3 times, correct?
Right. So
Okay.
up, down, 1, up,
Yeah.
down, 2, up, down, 3, done. Exercises come in pairs. Okay. One action gets you somewhere, the other action gets you back. Make sense? They come in pairs. That pair equals 1. Good? We know all of this. We know to follow the care plan. We know to do the opening. We know to evaluate if we need gloves, and we know to do the closing. There's nothing new here for us to learn, but we do want to go over the rules for range of motion. I know it says review. We haven't gotten to it yet, so we're going to go through this from scratch, okay? This is what we need to remember to do range of motion. Now, this applies to all 3 range of motions we're going to learn. Right now, we're working on hip, knee, and ankle, okay? But this still applies to the shoulder. This still applies to the elbow and wrist. This does not change based on the body part. Good? Range of motions are the easiest. All right, so when you get your care plan, you want to pay specific attention to the body part, right? Where are we working? The exercises that it wants you to do, and the number of repetitions. And as long as you follow that, you're golden. So in this case, our body part is the right hip, knee, and ankle. Our exercise is flexion extension, and our number of repetitions is 3. Okay? So when we're lifting, you've heard me say this before, this is not new. When we're lifting, we lift from below with a flat palm, never from above, right? Lift from below with a flat palm. So we're providing support. And we want to provide support near the joints. We're going to move slowly and smoothly. And this is probably the part that students struggle with the most. Return all the way to the start position. Students kind of try to shortcut this. Don't shortcut this. And I'm just going to show you on my shoulder just so you can understand. Flexion extension, we're about to learn, is an up-down motion, okay? So my arm is naturally flexed, flexed means bent, right? So my arm is naturally bent. This is extension. If I extend my arm above my head like I'm asking a question, notice I said extend because it's straightening the body part. This is extension. This is flexion. 2 halves of 1 exercise. Good? So up and back down. That is a full range of motion because my arm stopped where it started. What a lot of students will do on the test is they go up like this. This is not a range of motion. A range of motion ends when you get back to start. You have to return all the way to the start position. Very important. Otherwise, you won't get credit for it. Good? So flexion extension is up, down. Okay, flexion extension is up, down. But on the leg, we have to modify it a little bit. And the reason for that is a nerve called your sciatic nerve. So when we're doing up-down motion on the leg, we're not going to do a straight leg raise like I did with the arm, right? Straight leg raise, right? Straight arm raise. We're not doing that because when we do, I'm going to show you a graphic in a minute that shows what happens inside the body. It stretches that sciatic nerve and can cause pain for weeks, months, years because we irritate that nerve. So when we are working on the leg, it's not a straight extension. We are going to bend the hip and the knee at the same time. So this actually looks, because we're bending the knee toward the chest, kind of looks like they're walking up steps. Okay. But this is a flexion of both joints at the same time. So flex the knee to the chest and then bring it all the way back down straight to the bed. Flexion, extension. Good? Good? All right, and this is why. Knee and hip at the same time. This nerve, right? This comes off of your spinal cord. So your spinal cord comes down through the center of your spine, branches off into a million nerves as it goes. When it gets down here to around your tailbone, it actually branches off into two parts. Goes down to feed your legs. And they're big. See how big that nerve is? Big nerves that run down the back of your leg. Well, when you lift the leg straight, it pulls right here. It pulls that nerve taut. Think of a rubber band that is 60 years old that you found at grandma's house in the back of a drawer. You try to stretch that thing and it doesn't stretch. That's what happens here. It'll break. Our nerves don't break though. They just get super irritated and scream at the person for like months. They're grumpy. So we don't do this. When you, let me go back one. When you bend the hip and the knee together, that keeps slack in that nerve. It keeps it from getting pulled super tight. Good? Good. This is what they want you to know about range of motion, hip, knee, and ankle. Make sure you're bending the knee as well as the hip. Good. All right, so that was hip and knee. We did that together. So range of motion, hip and knee. But our care plan said hip, knee, and ankle. So we got to do one more body part. We're going to come down to the ankle. Hip and knee we'll do together. Ankle we're going to do separate. And when we do flexion extension of the ankle, we're going to bend the foot forward like they're stepping on a gas pedal and then back up to the head. Just a little bit. This is going to stretch along the back. Okay, so just a little forward and back. What this does is it keeps the tendons from contracting up, which can cause the feet to bend forward permanently. They're called contractures. We're trying to prevent that. So we're going to bend the foot forward toward the head and or back toward the head and forward like they're stepping on a gas pedal. Doesn't matter which one you do first, but forward and back, just do that full range of motion. Wherever you start is where you end. But when we're doing this, you want to make sure that that heel is not resting on the mattress. Because if the heel is on the mattress, when you're moving it, it's going to scrape. And skin that's very thin and tissue-like can tear or abrade. So we don't want to do that. So when we're working on the ankle, we're going to support it from below. Just lift it off of the bed a little bit. Doesn't have to be a lot. We're not doing a straight leg raise. Just a little bit off the bed to keep it from scraping. So lift that heel up, bend forward and back, forward and back, forward and back. Put the foot back down. And as we're doing all of this, we want to be asking the patient, are you feeling okay? Are you having any pain? Is everything good? Now, I told you that there are 3 exercises that CNAs can do. Okay. Flexion extension is one of them. Flexion extension is up, down. Another exercise that the CNA can do is abduction, adduction. When you abduct a child, you take it away from its family. Don't do that. That's bad. But when you abduct, that means taking it away from its family. So if I abduct an arm, I take it away from its family. Adduct is the opposite. We're bringing it back in. So adding it back into its family. Abduct, taking it away. Abduct, bringing it back in. Now, we can do this to the leg if the care plan told us to. And that's just sweeping the leg to the side. Abduct, adduct. Okay. Not all joints can move in all directions, so we're going to follow the care plan. Did our care plan tell us to do abduction, adduction for this patient? What did our care plan say? There was one exercise. Flexion, extension. So are we doing this for this patient? We need to know how to do abduction, adduction, but it doesn't apply to this patient. Now, there's one more exercise that CNAs can do, and that is called rotation. Rotation is around. Now, the other two had two movements to make one, right? Flexion, extension made one. Abduction, adduction made one. Rotation is just one. It doesn't have a counterpart because you always end where you started. You go around to end where you start. A rotation is an around motion. Now, there's very few joints in the body that can go around. So we only do rotation when our care plan tells us to do rotation. Because if you try to rotate an elbow, you'll break it. Okay, so we always follow our care plan. This care plan, very specific, flexion, extension of the hip, knee, and ankle. We know the hip and the knee is done together. So we'll do flexion, extension 3 times to the hip and knee, flexion, extension to the ankle 3 times, do an opening and a closing, and that's it. Mm-hmm.
Are we only going to be doing, will there only be flexion and extension, or is there going to be?
This is the exact care plan for range of motion, hip, knee, and ankle. So keep your fingers here, okay? Turn back to page 25 for me. Ow, 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 ow. Okay, if you look at the very first clipboard, you see that very first clipboard? Do you see the one in the middle? It says perform passive range of motion, hip, knee, and ankle. It is the same care plan that we just looked at. Okay, but if you look at the next one, it's perform passive range of motion, elbow, and wrist. We still have to learn that. All those same principles apply. So basically what we want to know is what exercises and what repetitions. Which side am I working on? The one in the very middle is another range of motion. The first one in the bottom row, the second one in the bottom row are range of motions as well. It's very common to have a range of motion as an assigned skill on the exam. Over half of these have a range of motion skill on them. But they're also the shortest skills we have. So that's actually a win for us. Good? Good. Make sure that you're monitoring for pain throughout. Make sure the patient understands what you're doing as well. You do not want to go into a patient's room, pick up a body part, and start moving it. They'll resist. They don't understand what you're doing, why you're doing it. They'll resist. So you need to explain to them what you're doing. Get them on board. Get their cooperation, and it will help. All right, so let's use these principles to check off this checklist. And to do that, we're going to follow the care plan. We're going to do our opening and get all of those checkpoints. Look at all of that we're getting. We haven't even started the skill yet. We're going to evaluate if we need gloves. We probably won't for the test. We are going to support the extremity, lift from below with a flat palm, move slowly and smoothly, return all the way to the start position, and do the exercises as indicated in the right amount of repetitions. And then we'll do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Environment's clean. Bed's in the low position. Open the curtain. Wash my hands. I'm done. Okay. Takes longer to do the closing than it does to do the skill, to be honest with you. All right. So this care plan's only for this guy. That's it. All these other people have different care plans. This one doesn't have range of motion at all. He's a walkie-talkie. He does everything on his own. I don't need range of motion on him. This one, she needs range of motion, but only on her shoulder. This one is a total care. She needs everything done. How do I know who's who? Care plan. Absolutely. All right, Jake, we're going to show the video for a range of motion, hip, knee, and ankle, please.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
Okay, I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, after washing my hands, we're ready to get started. The first exercise I'm going to do is bring your knee up to your chest and back down to the bed. I'll do all the work. All you have to do is let me know if there's any pain or discomfort. We're going to provide 2 points of support, one under the knee and one under the heel. And we're going to lift up and all the way back to the bed. Feel okay?
Yes.
Any pain?
No.
We're going to do it again. Up and all the way back. And one more. Up and all the way back. Feel okay?
Yes.
Okay, now I'm going to work on the ankle. I'm going to lift your leg off the bed just a little bit, and then I'm going to bend your foot forward and back. You should feel a little stretch. Please let me know if there's any pain.
Okay.
So I'm going to lift under the ankle. We're going to bend the foot forward and then back. Feel okay?
Yes.
We're going to go forward and back. Feel okay?
Yes.
One more, forward and back. Good?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Are you comfortable?
Yes, ma'am.
Environment is clean. Bed is in the low position. Here's the call light. If you need anything at all, just press the red button and we'll be happy to come help. I'm going to open the curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Not bad, right? Yeah, I would want I would want a range of motion. And they show up on about half of our care plans for the test. So you got a pretty good chance of getting a range of motion. Remember, shoulder, exactly the same, right? We look at the care plan. It tells us what body part, what exercises, and how many repetitions. Elbow, wrist, exactly the same. We look at the care plan. It tells us what body part, what exercises, and how many repetitions. We just follow that. I'll show you those a little bit later on in the program, but that's what range of motion is. Super easy. All right, good? Good? All right, let's go ahead and take our break. I'm trying to figure out whether we should wait till after. This is kind of a long one. I have to explain to you what dentures are and how to clean them, and so this takes a little bit of time. So we're going to go ahead and take our break a little bit early today. When we get back, we're going to do denture care and ambulate and then partial bed bath. Partial bed bath is the longest skill that we do. We have 19 minutes to do it. Longest skill. But you already know 99% of what you need to know to do that skill. You already know 99%. I'm going to have to teach you the last 1%, which is really, really cool. It's a really cool way of using a washcloth. So we'll get to that as well after break. So let's go ahead and take our break, 15 minutes. Uh-oh. All right, and we're back. Okay, so page 96 is our overview of denture care. Down the side, you can see all the principles that are involved. They're all spelled out for us here. We know everything, all these principles we've already learned. We're going to learn the skill-specific steps. This is our short version here. Down here, you can see test-specific information. Somebody with your level of experience, which is none, should be able to do denture care within 13 minutes. This is also going to be done on a live testing student, but before you guys freak out, none of you have to go get dentures before this, this skill. It is a live patient skill, but nobody's going to be putting dentures in your mouth and nobody's going to be taking dentures out of your mouth. And the care plan was written specifically to address this. We're going to look at the care plan in just a minute. Your patient will be positioned in a chair at the beginning of the skill. Documentation is not required. Page 97 has our step-by-step instructions. Care plans at the top. We'll look at it together in a minute. Down here are your supplies. There are a lot of supplies for this skill. There's a lot of supplies. You have to learn your supplies. So if you have not made flashcards yet, this is a good time to start so you can start learning these supplies, okay? Step-by-step instructions there, but let's look at the care plan. It says a resident with dentures is sitting at an overbed table with their dentures in a denture cup. So stop there for a second. Dentures are already out of the mouth in a cup at the beginning of this skill. That's important because CNAs cannot take dentures out or put dentures in without additional training. Your patient has to be able to do that themselves. And there's a very good reason for this. If you are taking dentures out of somebody's mouth, those dentures are generally held in with denture paste and suction. They also may be mini implants, in which case they're actually secured by posts that are in the drilled, surgically implanted in the gums. So this requires a pretty significant amount of force to remove dentures. If I am in my own mouth trying to get dentures, this is particularly important on the bottom, okay? If I am trying to get dentures off of my bottom jaw, I take my fingers, put them all the way in my mouth, all the way to the back to get that back corner, and I get underneath the dentures, pop them up and forward to get them out. That's how dentures are dislodged. And if you're doing it on yourself, it's fine because your force, your force is upward, not downward, okay? But if I put my hands in somebody else's mouth to pop that denture up off of that lower jaw, these knuckles right here, in order for my fingertips to have force upward, I have to have equal force downward, which means that these knuckles press down on that bottom jaw in order for my fingertips to press up. You can dislocate somebody's jaw. So because remember, it requires a pretty significant amount of force. We do not take dentures out. Your patient has to be able to do that on their own. If they can't take their own dentures out, no problem. They don't wear them. We puree their food. Good. Now, in is a different kind of problem. CNAs don't put dentures in a mouth either, because when you put dentures in, that patient will, without thinking about it, it's an automatic reflex. When dentures go in, they bite down to get them seated on their gums. Where are your fingers? In their mouth. They will accidentally bite you. It won't be on purpose. It is a reflex. And if you don't get your fingers out of the way quick enough, you will get bit. So CNAs don't take dentures out. CNAs don't put dentures in. That has to be something the patient does. And if not, not a big deal. We will puree their food so chewing isn't required. There's a plan in place for that. Good. All right. So it says the resident with dentures is sitting at an overbed table with their dentures in a denture cup. So we're not taking them out. The resident's denture needs to be brushed with toothpaste, and the resident needs mouth care. The denture is stored in a denture cup after cleaning. So our care plan is telling us don't put those dentures back in somebody's mouth. They're in a cup at the beginning. They're in a cup at the end. And if you try during the test to put dentures in somebody's mouth, the evaluator is going to stop you and say, the care plan says. Now, you did not follow the care plan. How is that going to affect your grading? That's right. This is important, right? Care plans are important. So you have to understand this care plan. Good? Good. All right. It says the resident's not able to provide their own mouth or denture care. I'm going to tell you that mouth care is an intensely personal skill. I would say that mouth care is actually harder for patients than peri care in a lot of cases. I don't know what that, there's some psychological reasoning there, but mouth care is very personal. Denture care, even more so. Patients with dentures don't like people handling their dentures. They just don't really like it. Okay. Part of that is cost, because you're not going to take as good a care of dentures as your patient does, because they know if they break, the patient has to replace them. Right. And dentures are like $5,000. They're expensive. So if you're dropping dentures, if you're not paying attention to what you're doing and they break, that patient is the one that has to pay that price. So patients aren't just like, yeah, everybody, take care of my dentures. This is only going to be done if your patient cannot do it themselves. Make sense? Good. All right. So for this skill, we have a patient sitting. Let me get rid of all this stuff. Hold on. We have a patient sitting at an overbed table with their denture in a denture cup at the beginning of the skill. This is how the skill starts. Your job is to clean the denture and to clean the mouth that denture came out of. That's what you are going to do. Your patient's going to stay right here. They're not going anywhere. They stay right here. You're the one that's going to go and come. Okay. But in order to understand this, we have to talk a little bit about dentures themselves, because most of my students aren't real aware of dentures or comfortable with them. So we have to kind of demystify dentures for a minute here. All right. So let's look at the denture part. So CNAs clean the dentures and the mouth that the dentures came out of. And it's important to remember that mouth care is part of denture care. Those dentures are usually held in with denture paste. That's going to hold food particles and proteins from the saliva, and it's going to hold it right up next to the gums. So if you don't clean the mouth those dentures came out of, that denture paste and those food particles are going to eat into the gums. And that can be absolutely awful for your patients. Kind of unrelated, but let me explain to you how awful this can be. One of the hospice patients I took care of was dying from a brain abscess that we tried to treat. It was untreatable, and it was going to kill her. And it was a brain abscess, and it was absolutely horrible. And she was a dementia patient that was nonverbal. So she was in an assisted living facility, and this assisted living facility did not perform good mouth care on her. She no longer had dentures. She couldn't put them in. She couldn't take them out. So she was on a pureed diet. And the aides there just did not take good care of her. and she pocketed food. This is very common with dementia patients. Food goes up in the cheek up here and it just stays there. Well, because she wasn't getting good mouth care, that food decayed and it ate into her gum, which ended up going into her sinus. Now, your sinus is right next to your brain. So the sinus got filled up with food that was decaying, ate through the bone, and got into the brain. And this is how we ended up with a brain abscess that ultimately killed her. What killed her were aides not doing good mouth care. That's horrible. Horrible. Criminal. Neglect. So when we have somebody who cannot perform their own mouth care, especially if, they're pocketing foods, they have dementia, they have dentures, that food is going to get stuck up there. You've got to make sure you're doing a good job removing that so it doesn't eat into the gums. Make sense? Good? It was awful. When I saw her, when I went to admit her, I mean, she them off. This is just awful. What tipped them off that there was a problem was that she developed a sore on the outside that looked like a pimple. And, it was very odd. People that old generally don't get a lot of acne, so it was very odd. But nobody looked inside. Everybody just focused on the outside and they put some cream on it. Well, when that thing erupted, it actually ate her cheek. So she had, that's how they found it. That's when they were like, oh, there must be something wrong. It ate her cheek. So when I went to see her, it was a Freddy Krueger situation. I mean, she had nothing there. You could see straight in. So CNAs, when I tell you observe and report, you guys are the last line of defense. If you see something and you don't report it, if nothing is being done, if the patient has horrible breath and nobody is addressing that, these things can get away from us really, really quickly, and then patients pay with that with their lives. So this isn't just one of those, it's a skill I have to learn for the test. Everything that I'm teaching you literally can mean the difference between life and death. It's not just pericare. It's not just denture care. It's not just range of motion. If these tests aren't done and aren't done correctly, they can ultimately kill your patient. The gravity of this is important because we tend to lose sight of that in the day-to-day mundane routine. Okay? Having to call that patient's family was probably one of the hardest things I've ever had to do as a nurse. That was over 20 years ago, and it still stays with me. We failed her. We should have done better. Okay? So when it comes to dentures, there are 3 different types of dentures that you are most likely to deal with. So when we talk about dentures, the kind that most of us are familiar with are these. This is called a full plate. It replaces all of the patient's teeth. This is a top plate because it has a palate. This goes up against the roof of your mouth. If it doesn't have this part, it's a bottom plate because that's where the tongue goes. Right? So see how there's a cutout for the tongue. So this is a top plate. Replaces all the patient's teeth. This is what we call a full plate. So the patient has none of their own teeth left with this. Not on top anyway. But if the patient still has some healthy teeth, we don't pull healthy teeth, bless you, to replace them. We will work around the healthy teeth and leave them in place. And we will fill in the gaps, the missing teeth. This is called a partial. So the partial has where we're replacing missing teeth, and it has gaps for the healthy teeth that remain. Usually it'll have some sort of a loop or bracket to attach to the other teeth that still remain. This does not. This just goes on with denture paste and suction. So we have full plates and we have partials. They're both cleaned the same way, but you may see both of them. They're used for different cases. Good? Questions? Okay. There's also another type of denture, bless you, another type of denture, which is just a little piece of a denture that clips onto the teeth around it, and that's called a bridge. Most bridges now are implanted. They don't come out. They're permanent. So what we're doing now on people is usually implanting missing teeth if you've only got one or two missing. But your older patients may still have a bridge, which is a removable section of a denture. We clean them all the same way. We deal with all of them the same way. You just might see different configurations, and I like to make you aware of the different options that your patient may have. Okay, so there's two ways to clean dentures. Our care plan is going to tell us which one to use. So the first way is the one our care plan is telling us, and that's clean the dentures with toothpaste and a toothbrush, or, a brush of some sort. So we're going to take the teeth to the sink and clean them just like we would clean them in the mouth, right? We're going to brush them. But the other way is probably way more common, and that's fizzy tablets. Now, fizzy tablets, you put the dentures in a cup, fill it up with cool, clean water, put the fizzy tablets in there, put a cover on it, leave it for a little while, and those bubbles actually break down the molecular bonds of the food, the proteins, and the denture paste. It actually is, in a lot of cases, preferred to use the fizzy tablets. Now, we like brushing things with toothpaste because that's what we do on ourselves. We feel it's a little bit cleaner. The problem is that toothpaste is an abrasive. And when we use a brush and an abrasive paste, you can actually form little micro cracks on the dentures that are going to harbor bacteria. And it can actually shorten the lifespan of the dentures. So your patient will have a preference on how they want their dentures cleaned. The nurse will figure that out during their assessment. They will put that information on the care plan for you to follow. This care plan tells us to brush with a brush and toothpaste. So that's what we're going to do. Good? But understand there is another way that maybe your patient out there may prefer. So in order to brush the dentures, we're going to use a special brush. This is called a denture brush. It has two sides. One of them looks like a toothbrush. That's what we're going to use on the teeth part of the dentures. So this brush is going to brush the teeth. This side is narrower and it's tapered, it's pointed. This is designed to fit in the groove. Okay. So this is specifically designed to fit here. This doesn't fit there as well. See how it kind of goes over? So this is designed for the groove. This is designed for the teeth. So we use a denture brush the same way we use a toothbrush. We get it wet first. We put some toothpaste on it, and then we put it in the basin just to hold it while we get everything else ready, right? That basin is just there to hold it. You do not want to set your prepared denture brush on the side of the sink. That's gross. Don't do that. This is why we put it in the basin instead. That basin just holds that denture brush until we're ready. We're not ready yet. We've got the denture brush ready, but we're not ready yet because there's a couple more things we have to do before we can get started. So we put it on in the basin, put the basin on the side of the sink while we continue to get ready. Still on prep work. Still no gloves. Still on prep. One of the things that we have to do here is make sure that we keep those dentures safe. If we drop the dentures, they may break. And they're expensive. So one of the ways that we keep dentures safe is to always keep them either in the cup or in our hand. If you need to set them down, put them in the basin if those two things aren't available, but never put them in the sink. Good? That sink just isn't as clean as you think. Basin, denture cup, hand. Preferred hand and denture cup. Basin if you have to. Good? All right. We also have to protect those dentures in case they do fall, because we're brushing something that's wet and covered in toothpaste. It's going to be slippery. And we have gloves on, so our tactile information is decreased. So it's possible you might drop these dentures, and we want to protect them if they do fall. So always stay over the sink with your dentures. Don't, carry them around. Don't bring it over the floor. Over the sink. Lower is better so they don't have as far to fall if they fall. But one of the main things we're going to do is put a washcloth in the bottom of the sink or a towel, something absorbent and soft in the bottom of the sink. That way, if the dentures do fall, they're falling on a soft surface. Now, if you can get that washcloth over the drain, even better, because that lets the water pool up in the sink. And now we've got a break. So if the dentures fall, they hit the water and then they slowly sink down. Okay. So we've got our denture brush that we're prepared. It's in our basin. It's on the side of the sink. We have a washcloth in the bottom of the sink. Still no gloves yet. Still no gloves yet. And then we have to turn the water on. Okay. Then we have to turn the water on. Now, do we want to touch that faucet? What can we use between our hands and that faucet? A paper towel. So we're going to get a paper towel to turn that water on, and we're only going to use cold water, not hot water. Hot, there's a principle. Heat coagulates proteins, which probably doesn't mean anything to you, but what it's going to do is make everything on that denture stickier and harder to remove. We don't want that. Cold water, please. Okay, cold water. All right. So once we have the water running, now we can put on our gloves. Now we're ready to start. So we've got our basin holding our prepared denture brush. We've got our washcloth in the bottom of the sink. We've turned the water on with a barrier. It's cold water. We put our gloves on, and now we can start brushing the dentures. Remember, keep them in your hand over the sink. Brush all surfaces. Top, the bottom, the groove, the teeth, the whole thing. Brush it all, but keep it over that sink. Once you've brushed, you're going to rinse. And again, hold on to that denture. Don't set it down in the sink. Rinse all surfaces. Keep the dentures in your hand. Once you've got the dentures rinsed, we're going to rinse out this denture cup. Okay, because it's just sitting there. I've got the dentures in my gloved hand. I've brushed, I've rinsed, I'm holding. I'm going to pick up this cup, rinse it out, fill it up with cool water, and then put my dentures in. And that's where they live. So that's the denture care part. There's one more step because we can't keep the dentures at the sink. If your patient wants to wear the dentures, having them way over at the sink isn't going to help your patient at all. We've got to bring this denture cup with these dentures back over to the patient. For the test, we're going to set it on the bedside table. We're not going to put it back on this table. You can if you want to, but put it on this table. It's where they expect it to go. This cup has just been rinsed. It's wet. Do I want to put a wet cup on furniture? So what could I put underneath that wet cup? A paper towel. So we're going to grab a paper towel as a coaster to put underneath that cup and put it back over here on our bedside table for your patient to use whenever they want their teeth in. But I'm not quite done yet. Okay, my dentures have been cleaned. My cup has been rinsed. My dentures are in my cup. The lid is on it. It's on a paper towel on the bedside table, but I still have a whole bunch of stuff going on at that sink. So I'm going to go back to the sink and I'm going to rinse out that washcloth and put it in dirty linen. And I'm going to grab my basin that's holding my denture brush because I'm done with it. I rinsed it out, put it back in that basin just to hold it. Remember, we can't put denture brushes on the side of the sink. So I put it back in the basin. It's just holding it. I need to get that basin and bring it over to my table because I still have to do mouth care. And I need that basin for them to spit into with mouth care. So I've got the dentures cleaned in a cup on a paper towel on the bedside table. I go back to the sink. I take care of the washcloth, and then I grab the basin and denture brush and bring it back to the table. I'm going to take the denture brush out, put it on the barrier, put it to the side because I need that basin clean for my patient to spit in. And then I'm going to take my gloves off because I'm done with denture care. Do you think the patient wants those gloves in their mouth? Think of all the things those gloves have just touched. Do they want those gloves in their mouth? No. So this is a hard skill because it requires a glove change. So when do you change gloves? When you're done with denture care. Right, right. So everybody clear on that? We cleaned the dentures, we stored them, we cleaned up, we brought our basin back, and we removed our gloves. That's set one. So it might be helpful for you to divide this skill into part 1 and part 2. Good? Make sense? I'm going to tell you, this is one of the hardest skills for students to learn because it does involve a glove change and it's kind of a long skill with a lot of steps. So in your mind, if you can kind of divide it up into part 1, clean the dentures, and part 2, clean the mouth, which we already know how to do, mouth care, it makes it a little bit easier. Now, a question I get asked a lot, can I do the mouth care part first? And the answer is yes. There's nothing that says that you have to do dentures before mouth care. You can, but it's actually going to make it harder for you. It's going to add another step. Because when you do mouth care, the patient has to spit in that basin, which means you then have to go clean the basin before you can prep for denture care. And then you have to clean it again at the end of denture care. So it requires a lot more steps for you. That's why I have it set up where you do denture care first and then mouth care. But for the test, there's no order here that it has to be done.
You just said we know mouth care.
You do, because we learned it last class.
Brushing the teeth we did.
Right.
But mouth care, now we're talking a mouth with no teeth in them. So
Right. And so I'm going to go over that in detail in just a second.
Oh, okay.
But the process is exactly the same.
Well, then let me tell you again. You just explained to us about a lady who had food in her cheeks.
Right.
So to me, just brushing teeth, we're not able to see
Or
know that there's.
Yeah, we're going to brush top, bottom, front, back, just like we would with a toothbrush, but we're not going to use a toothbrush this time. So, yep, I'm going to cover that. Okay. So this skill requires 2 sets of gloves, 1 to brush the dentures and 1 to brush the mouth. Everybody clear on why? 2 sets of gloves. All right, so to do mouth care, instead of using a toothbrush, you're going to use something specific. This is a toothette or oral swab. The reason we use this is because denture paste is sticky and will kind of stick to the gums, and it's going to hold food particles. And if you use a brush, after like just a little bit, that brush is going to get all gummed up and it's not going to be as effective. So we use this instead. It's a solid surface. It allows us to swipe much more effectively. But it also, because it's solid surface, it has 4 distinct surfaces. So I have 1, 2, 3, and 4. So I can swipe the top, turn it the bottom, turn it the top, turn it the bottom. And if I still have a lot of denture paste, I can go get another one and do it again, right? So I can use these, but this is disposable. So we're not trying to clean it off after. It's going to have a lot of denture paste and other things, you know, food particles on it. It's much more effective to use a solid surface than a brush surface for cleaning gums, and there may be some, this can be used on teeth as well, but it's soft, it's spongy. It's solid, but it's spongy. Okay, good. Questions?
So, this is only for people with dentures?
Well, so yes, you could use this for somebody with teeth. You could, and there are some situations where the care plan will tell you to use an oral swab or a toothette instead of a toothbrush, particularly if the patient has thrush, because that causes all of those tissues to be very inflamed, and a brush can be a little too abrasive. So sometimes, even with patients with teeth, you'll be told to use this. We always go by the care plan. Whatever the care plan tells us to do, we'll do. But even if your patient has full dentures, all they're going to have is gums in there. But if they have a partial, they may still have a few teeth. You can use this on just gums, and you can use this on gums and teeth. Okay. But ultimately, we always go by our care plan if it specifies. If it doesn't specify, you can use.
So we would brush the teeth and then swipe the side?
No, just use this. So, okay, let me back up. Something that you probably don't know about brushing teeth. Most people brush their teeth too hard. Like, you use some force. You're like in there trying to dig for gold, right? That's actually not effective. And it's actually not healthy either. A gentle motion, we should be sweeping things away, not digging for gold. Okay. So this is going to accomplish what mouth care should accomplish just by a gentle swiping motion. And again, if you've got a lot of teeth, you may need 2 of these. Okay. For the test, so I want to separate this test and clinical. For the test, your patient is one of you. You have teeth. So we're just wetting, putting toothpaste on it, and swiping the top, the bottom, the front, and the back, just like you would with a toothbrush. You're going to use it like a toothbrush. However you need to do it, right? You're not graded on how long. You're not graded on how effective. You're just graded on doing it. But in a clinical setting, you're probably going to, if you've got teeth, you're probably going to need more than one of these. If you've got gums, you're definitely going to need more than one of these, because gums are going to hold that denture paste, and this is going to get gummy pretty quick. But for the test, we're only using one, and we're going through the motions. Okay.
I just think, like you said, you just told us a story about a lady with food stuck up there, that the mouth care with no teeth.
Okay, so here's the thing. With that particular lady, the aide that was responsible for that unit for AM care was not doing mouth care on anybody at all. At all.
Okay.
At all. Nobody on that unit got mouth care. So this wasn't a situation where it just wasn't done well. This was a situation where it just outright wasn't done. Okay. So sorry, I should have clarified that. It just
It's okay. I'm just saying
absolutely.
that the mouth care was going to be more of a.
So here's a question.
Really getting more of the gum.
Yeah. So here's a question. When you're performing, and when you do this, you're going to see that this actually is way more effective than you think it's going to be. Okay. But let's say that you're working in a clinical setting and we've got a patient with dementia who you're doing mouth care on and it's just gums and you're using a toothette and you're getting in there, but you just don't know that it's being overly effective. Who would you tell? The nurse. And the nurse will come up with another option. In some cases, with some patients, I use a water pick. And that sprays water and pushes the food away before I have the aides use the toothette. So I've got a lot of tricks in my little magic bag. I just need to know which ones I need to use on which patients. The only way for me to troubleshoot is to know there's a problem. The only way for me to know there's a problem is for you to report it. Good. I can solve pretty much every problem you come up with. Might take me a minute. Might take me a minute. Yep. It can. It can. But thankfully, mouths are not as big as you think they are. Some of us, feel like we might have some big mouths, but they're not as big as you think they are. And this does a really good job most of the time. Okay, good. So let's review mouth care because I told you already know mouth care. Let's review mouth care. We make sure the patient is sitting up. Well, they're already sitting at a table. Good. We have to protect their clothing, so we're going to put a towel on this. We're going to prepare our brush, in this case, our toothette, by dunking it in water and putting some toothpaste. Little toothpaste goes a long way, remember that. And then we're going to lay it in our basin just to hold it there until we're ready to use it. Now I've got everything prepped. What's it time for? Gloves. So that's when I would put on my gloves, and then I'm going to brush. For the test, they're not timing you. They're not getting in there and seeing what a great job you did. They're not making you chew those little pink pills, to get all kinds of stuff on your teeth and then having you wash it off like you did in first grade. They're not doing anything like that. You're just going to brush. Just show that you would do that step.
I remember for mouth care that they were able to be on the bed. We would just raise the bed.
So for mouth care, they were on the bed. But for this skill, if you look at the top of page, is it 91?
Oh, yeah, 96.
96? Yeah, where does it say they're going to be? Yeah. So mouth care, the patient was in bed, and our care plan told us that. For denture care, the patient's in a chair, and the care plan tells us that. So your patient's already sitting, so we don't have to worry about that step for denture care. For the test, let me clarify that. For the test, in a clinical setting, if I've got to do denture care on her and she's laying down, what do I need to do? Sit it up. Yeah. So remember, every patient that we work with is going to be a little bit. This patient for the test, just this one, is sitting in a chair. Yay.
So if they can't get up, we would just raise their bed.
Right. Raise the head of the bed. Yep. Yeah. If your patient can get to the bathroom, it's the best place to do mouth care. Best place, hands down. But if your patient can't get to the bathroom or doesn't have the stamina to stand in the bathroom, then we would do it in a chair or sitting up in bed. But they have to be upright for mouth care. Good. Good. So then we're going to perform mouth care. So you can see that toothette, right? So our patient for the test is going to have teeth just like he does. You can see that toothette, because it's pretty long. I mean, it's going to get in that back corner pretty quick. So it does a really good job, way better than you think it's going to. He hates this skill. He really does. All right, and then we're going to let them rinse and spit as long as they need to, as much as they need to. And of course, dry their face. We've gone over this step quite a bit. Dispose of our linens properly. We're going to rinse our basin and rinse it, dry it, store it. clean up your environment, remove your gloves, clean your environment, do your closing, and that's the skill. So I'm going to pass this around for you guys to be able to see the different supplies as I'm showing you the video. So you've got the basin that's going to hold your prepared denture brush. You've got your toothette, and I'm going to pass around both. Do this. Both dentures for you to be able to see the difference between a partial and a full plate. So you guys can kind of play with these a little bit. One note about dentures, they need to be stored in water. Now mine are not, mine are just a classroom set. They are real dentures though. They've never been in anybody's mouth, but they are real dentures. Mine is a classroom set, but in real life, dentures must be stored in water. Otherwise, the material that the dentures are made out of becomes very brittle and it can break. So dentures should be stored in water, unless, I will caveat to that. Technology changes all the time, right? Your patients mostly have the older style dentures because you're working usually with an older generation. New dentures are made of a different material than the old denture. Some of the new ones are way more expensive, but the denture material actually flexes. It's much less rigid, more malleable, and those don't have to be stored in water. So there is a new type of denture that doesn't have to be stored, but it's way more expensive. And it's still kind of very new, so it's not used all that often. If in doubt, ask the nurse, look at the care plan. If it doesn't have to be stored in water, the care plan would tell you that. Okay. All right, Jake. Oh, okay, yeah, go ahead. That's good. No, it was me.
Hello.
Good afternoon, Mr. Jones. How are you?
I'm well. How are you?
Wonderful. My name is Patty. I'm your CNA today, and I would like to help take care of your dentures and perform mouth care. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to take your dentures to the sink to clean them.
Okay.
I'll bring the denture cup to the sink on the paper towel. We're going to set it on the side of the sink and open it, placing the lid beside it, and then wash my hands. After washing my hands, I'll get my supplies. We're going to start with a barrier. This is going to provide a clean place to put our clean supplies. So we'll spread the barrier out on the table with the absorbent side facing up. And for this skill, I'll need a towel and a washcloth, being careful not to let the supplies touch my uniform. I'm just going to go gather the rest of your supplies. I need a toothette, a denture brush, and toothpaste, along with an emesis basin and a cup of water. We'll set these on the overbed table. And I need 2 sets of gloves. Okay, I'm going to get the denture brush ready. We're going to wet it and apply just a little bit of toothpaste on both sides. Set it in the emesis basin right now. I'm going to take the washcloth, a set of gloves, and the emesis basin holding the denture brush to the sink. Mr. Jones, I'll be right back. I'm ready to clean the dentures, so I'll set the prepared denture brush in the emesis basin on the side of the sink. I'm going to place the washcloth in the bottom of the sink over the drain and put my gloves on. I'll take a paper towel and turn cold water only on because we only wash dentures with cold water, and we're going to throw that paper towel away. Now I can clean the dentures. I'm going to take them out of the denture cup and rinse them off, making sure that I hold them over the sink at all times. I'll take the denture brush, and the small end of the denture brush is going to clean the groove part of the dentures. So we're going to clean that whole groove, all areas, and the palate. Then we'll turn the dentures over, being careful to hold them securely, and use the other side of the denture brush to clean the teeth part of the dentures. We want to make sure that we cover all surfaces. Making sure that we hold it securely. And then we can rinse the denture brush and put it back in the emesis basin for later use. We're going to rinse the dentures off, removing all of the toothpaste. We'll take the denture cup, dispose of the water, rinse it out, and fill it with cool, clean water, placing the dentures inside. Cover it with a lid. We can throw this away and get a clean paper towel to place underneath it. I can turn the faucet off, and we're going to go put this on the patient's bedside table. I'll place this denture cup on your bedside table over here for use later. Now I can remove the washcloth and place it in dirty linen. Now I'll bring emesis basin holding the denture brush over to the overbed table and take the denture brush out and set it aside. Now I can remove my gloves. I'll throw these gloves away. Mr. Jones, I'd like to place this towel over your chest while I perform the mouth care portion of this skill. Is that okay?
Yes.
I'll get the toothette ready. We're going to get it wet. Put a little bit of toothpaste on it. And then hold it in the emesis basin while I put my gloves on. Okay, Mr. Jones, I'm going to brush all areas of your mouth, the top, the bottom, the front, the back. So I need you to open up wide for me, please. I'm going to start in the back, on the top, both sides, and then the bottom in the back, the front, and can you bring your teeth together? Thank you. Okay, thank you very much, and we'll rinse. Okay, pour the rest of the water in there. And just make sure that your mouth is nice and dry. Okay, I'm going to place this in dirty linen, clean my basin, and then clean my work environment. I'll be right back. We'll take the basin to the sink and dispose of the contents into the sink. We'll then rinse the basin and set the basin down in the sink. We'll use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and then one more for the drawer. On the way to the drawer, we'll pick up the denture brush and the toothpaste, placing them in the emesis basin for storage. The supplies away, we'll use a paper towel to open the drawer. We're going to put the basin, toothpaste, and denture brush in the drawer, and then close it with the paper towels, and we can then throw the paper towels away. And now I'll dispose of all of my disposables. The cup, the wrapper, and the toothette, along with the barrier. These will go in trash. Now I can remove my gloves. We'll throw the gloves away. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean, your bed is in low position, and you're safe. Let me give you your call light.
Okay.
Here's your call light. If you should need anything at all, just press that red button and we'll be happy to come back and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done.
That in the video, you put your gloves on first and you grab the paper towel and turned on the water, because before when you were explaining it,
Yeah, it
you
doesn't.
did opposite. And I was gonna say, because I'm constantly thinking about water running and how many paper towels and how much waste that is and how much money. But it's funny that you did it in the video, because that's the way I probably would have.
And that's fine, as long as you're understanding that that faucet is not clean.
Yeah.
So whether you put your gloves on first or turn the water on first, it doesn't
Yeah,
matter.
I'm glad you did it, because I was thinking it.
And that's perfectly okay. You'll kind of do it both ways. It
Yeah.
just depends on where your brain is.
So when you dry the denture cup, because it's wet, like can you dry it first? And then
You
put it on
can,
one
yeah,
side?
you can, absolutely,
Okay.
absolutely. As long as it's on a barrier when you put it on the table, that's the checkpoint. There are a lot of steps. And like I said, this one seems to be kind of the hardest for students to practice. Now, I will tell you that for this particular skill, the practice kit becomes really helpful, because we actually have fake dentures in the kit for you. They're these. And they have a groove, just like dentures do. They obviously are not real. My mom makes these for us. But they have teeth and they have a groove. So it's a good simulator for you. You also get the toothettes and the denture brush in the practice kit. So this skill, the practice kit, becomes pretty important to help you, because these are things you probably don't have at home. The next skill as well, Ambulate with a Gait Belt, the practice kit has the Gait Belt. So the practice kit really is helpful. It has everything you need to practice all of the skills that we're learning here. Of course, we have all of this here for you when you're practicing here. But if you're not going to be able to practice here, or if you don't feel confident with the practice time that you have, the practice kit will help you. All right, moving on to Ambulate, which is page 66. This is a super quick skill. If you look down the side, you can see all of the principles involved in this skill. They're all spelled out below, but we have a new principle, shoe rules. We have not gone over shoe rules yet. So this is the last principle that we have to learn. And then that whole back wall is done. So we're going to spend some time learning shoe rules on this particular skill. At the bottom, you can see that somebody with your level of experience should be able to do this skill in 5 minutes or less. This is a super quick skill. Live patient skill, they're going to start out in a chair. Documentation is not required. Page 67 has your step-by-step instructions. So the top of the page has our care plan. We have instructions, and then at the bottom of the page is our supplies. Here's our care plan. Ambulate the resident at least 10 steps. Use a gait belt or transfer belt. It's the same thing, just two names. Gait belt, transfer belt. Patient will be sitting in a chair at the side of the bed with shoes on. So you don't have to put shoes on. They're already there, but we probably want to verbally acknowledge, I see you have shoes on. Patient is able to walk but needs assistance to stand. Have you guys ever seen an old person try to get up out of a chair? Kind of looks something like this, right? They start to rock. They're looking for momentum. They get that wide base of support. So they plant their feet. They rock. And then they, nope. Hold it. And they do it again, right? They rock. Right? How much energy did that take? Like a lot of energy. If I don't do this on wheelchairs, guys, you're going to fall. If I just stand up out of a chair, that doesn't take nearly as much energy as that whole rocking and multiple tries thing, right? What we have to understand is there is an inverse relationship between strength and effort. The less strength you have, the more effort things take. The more strength you have, the less effort things take. Now, you guys are all strong, comparatively speaking. So things are going to take less effort. The same task for an older person to do and a younger person to do, that same task is going to require more effort from the older person because they have less strength. Does that make sense? That's important for us to understand. And it kind of falls into shoe rules, which is what we're going to be learning about now. So we already know these principles, but we don't know this one. So we're going to concentrate learning about shoe rules before we learn this particular skill. And the lesson for this is going to be on page 63. So we just talked about effort, right? So if we have less strength, we need more effort to get the job done. Well, why do we care about that? Well, we have to care about that because energy levels across your lifespan do not stay at the same level. So have you ever seen a 2-year-old? 2-year-olds, 2 and 3, those are my favorite ages. Hands down, favorite ages. A 2 and a 3-year-old will jump up and down for no reason. They have excess energy. They just bounce, right? When was the last time you jumped up and down for no reason? Yeah. If I win the lottery, I'm jumping up and down, but I got a reason for that, right? I'm not just going to expel energy by jumping up and down if I don't need to. It's important to understand that because that is the maximum amount of energy that you have in your lifespan. It's downhill from there. And I'll prove it to you. Let's just go out 10 years. Let's go out to 12. 12-year-olds still a ton of energy. They skateboard, they play basketball, they video game, tons of energy. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? The 2-year-old. 12-year-old's like, Mom, can't they go take a nap? I'm tired. I don't want to deal with them anymore, right? That 2-year-old wins. Your energy level decreases in that 10-year time span. Let's go out to 22. 22-year-olds, still tons of energy. You guys can go shopping all day, go out at night looking fabulous. It's great. You got lots of energy, but you still do not have the same energy level you had when you were 12. Now go out to 42. 42-year-olds, we're shopping till we drop, but that's at like 1, and we're not going out tonight. Okay. Go out to 62. Now 62, we're putting our feet up for 10 minutes before we make dinner because we just need that rest. We're thinking about things like retirement because there isn't as much energy to be able to do household stuff and work full time. So we're thinking about energy. Now, what do you think those energy levels are going to be like at 82? Yeah, they're going to be very low. Now, remember I said that less strength requires more effort. Effort requires energy. So as our energy levels decline, we need more energy to do basic daily tasks. This is a recipe for disaster because we have less energy to draw on and we need more energy for basic things. Now, why do we care? Because old people, they just sit around all day. They got nothing to do and all day to do it. Why do we care? Everything you do, walking, talking, eating, breathing takes energy. Now, if we've only got this much energy to work with, and we got to do all of these things with that energy, and each one of these things takes more energy than it used to because our strength has declined, this is a problem. Do you guys see that? Energy conservation with the elderly is a very real topic, and it's one that we have to understand because this can set up what we call a downward spiral or a failure to thrive situation. Think about how much effort it took me to get up out of that chair when I was pretending to be an old person, right? Think about how much effort that took. Now, let's see how many times I have to get up. I have to get up out of bed and I walk to the bathroom. I sit down. I have to get up off the toilet and then I walk back to my room and sit down to get dressed. I get dressed. I have to stand up and then I have to walk to the dining room and I sit down. I eat and then I have to stand up and go back to my room to go to the bathroom after eating. And I sit down on the toilet and I've got to stand up off the toilet and go to the activity room. And I sit down at the activity room and watch a movie and then I've got to stand up. We're not even at 10 a.m. yet. Each one of those stand-ups took that amount of energy. Now, by the time I get to the afternoon, I'm going to be out of energy. And you want me to eat? Eating takes energy. The way to figure out if something takes energy is if you've ever been too tired to, it takes energy. Have you ever been too tired to talk? Have you ever been too tired to eat? Have you ever been too tired to shower? Okay, if you've ever been too tired to, that means that thing takes energy. So by the time we get to the evening, there is no energy left to eat. So we don't eat well tonight. What do you think that's going to do to tomorrow's energy levels? It's going to go lower. Can we afford for it to go lower? No. So a big part of what CNAs do is help the patients conserve energy. We lend them some of our strength. And this is one way that we're going to do that is by using a gait belt to help our patients stand so they don't have to do that rocking motion. And we're going to use our strength to offset their effort. Make sense? Good. If your patient tells you, I don't have the energy for that, don't argue with them. The real problem here, have you ever tried to explain to a 2-year-old why you don't have the energy they do? Have you ever had that conversation? I have. I had it with my kids and I had it with my granddaughter. I don't have that kind of energy. Do they get it? Ever? No. And the reason they don't get it is actually very important, right? This is their only frame of reference. They've never experienced anything other than this. So they naturally assume everybody else has what they have. They have no frame of reference. It's not until you get out here and you look back and you're like, oh man, I wish I had, if I could bottle that, I'd make a fortune. right? How many of you guys have said that? Okay, you have to get into a different energy segment to understand what you no longer have. Make sense? Your patient's way down here. You are way up here. Your patient is trying to tell you, I don't have the energy for that, and you're not going to get it, just like that 2-year-old did not get it. And you're going to do things like, Miss Margaret, you've got to take a shower. I do all the work. All you have to do is sit there. Come on, let me give you a shower. You're going to argue with them. You're going to try to convince them that they truly have the energy that you think they have. Do they? Not necessarily. So we all have basic circadian rhythms. How many of you guys are morning people? You like to get up with the sun. You like to hear the birds and have your coffee. Do I have any morning people here? No? I am not a morning person. How many guys do better somewhere in the afternoon? Kind of come alive around 4. Yep. Yeah. How many of you guys are my night owls? Night owls. Okay. So everybody has a different circadian rhythm. Some of you do really well waking up at 5. Some of you do fine waking up at 7, 7:30, 8, naturally on your own if you don't have anything to do. Some of you wake up at 10. Okay, we all have our natural rhythms. Some of you shower in the morning. I have to shower in the morning, otherwise I'm worthless. I have to have that get me going type of shower. Some of you shower at night. You want that relaxed before bed. Right? We all have different patterns. And our patterns are largely based on our energy levels and their fluctuations throughout the day. So if we have a patient who is consistently refusing a shower at night, that's something the nurse probably should know, because that patient might do better on a morning shower schedule. Make sense? If you've got somebody who's consistently refusing morning showers, they may do better in the evening. This is where we work as a team with our nurses. We make observations, we tell them, and they're able to do something with that information to better our patient's experience. Make sense? Okay. If you are trying to shower somebody when they are out of energy, they're going to fight you. Now, you might think they're not doing anything. They're sitting in a shower chair. But just the act of getting undressed, shivering, sitting upright, those are all things that take energy. Even though you might be doing the soaping and the rinsing and the drying, it's still taking energy for them. We need to listen to them. Encourage, sure. Force, no.
It could also be very random times too.
Sure, absolutely.
I have chronic fatigue syndrome, which we can talk about that all day, but I have to do what I can when I can.
Mm-hmm.
And it's like being an 82-year-old sometimes.
Right, right. Yeah, we have to listen to our patients. Good, makes sense? All right, so that's my conversation on energy conservation. A lot of the steps that you're going to be asked to do are done in mind with this energy drop in mind, okay? Understanding our patients may not have the energy levels we do. So we may be asked to help a patient using a gait belt to help offset their energy expenditure. Good? All right, so now we're going to switch over to a different topic, and still along the lines of shoe rules, but this has to do with diabetes. I'm going to give you a 5th grade watered down version of diabetes. This is overly simplified. So those of you watching on the internet, don't come at me. I know this is super complex, but this is a very simplified overview of diabetes. So you can kind of understand the risks involved and what we should be watching out for. So every cell in your body needs sugar. It's the fuel of the cells. Every cell in your body. Sugar gets a bad rap in our community, in our society. We think sugar bad. Sugar is not bad. Sugar in excess is bad, yes. But sugar itself is not bad. Your cells need sugar to run. It's a fuel source. That's like saying gasoline is bad. Well, your car needs gas to run. So the fuel cell for cells is sugar, but not usually in the form of pure sugar. We get our sugar through mainly carbohydrates. So when we eat carbohydrates, anybody know what an example of a carbohydrate is? Flour, pasta, bread, potatoes, rice, flour, sugar. We call it the rule of white. If it's white, it's probably a carb. Now, there are some exceptions to that, yes, but usually if it's white, look at it closely, it may be a carb. Okay, rule of white. When you eat carbohydrates, that becomes the fuel source for your cells. Those carbohydrates break down in the body into sugars, and the sugars release, they trigger the release of a key, because every cell, even though it needs sugar to run, the cell has to be opened for that sugar to enter. The cell is locked, has a door on it. It's locked. So we need a key to open the lock for the sugar to go in. That key is actually made in your body by an organ called your pancreas. Your pancreas produces insulin. Insulin is the key that opens the cell. Good? So you eat carbs, your body says, carbs, break it down. Pancreas needs some insulin. Pancreas goes to work, creates the insulin, dumps it in the bloodstream. Now those keys open the door, the sugar goes into the cells, cells are happy, and they can function and run well. You guys understand that system? Okay. So insulin's job is to unlock the cell. Cells are starving. They send a signal to the brain, I'm hungry. Brain says, go eat. We eat carbs. Those carbs break down. Pancreas produces insulin. The key opens the door. The sugar goes in. Cell is happy. Where this goes wrong with diabetes is that we don't have keys. So cell is starving, sends a signal to the brain. Hello, hungry. The brain says, oh, we need to eat. So you eat. That sugar, those carbs break down into sugar, goes into the bloodstream. The brain says, hey, pancreas, we need some keys. The pancreas is like, can't help you. Offline. Not working. Now, what happens then is the cells are still starving. So the cells are like, brain, we need some fuel. So the brain goes, got it. We need to eat. Carbs, please. And we kick up a craving. We eat carbs. Those carbs break down into sugar, goes into the bloodstream. Brain says, pancreas, needs some insulin. No answer. The cells say, I'm starving. And at this point, the cells are like, I'm dying. And they mean it. This is not arbitrary. Your cells die because they don't have fuel. So the brain's like, we really need some carbs. So this is when we really get our cravings for M&Ms and cookies and all the sweet stuff. This is why your diabetics crave sweets. It's because their cells are literally dying. So when you tell a diabetic, why are you eating those M&Ms? You know better. You're diabetic. What are you, stupid? No, they're not. They're dying. Now, the problem is that those M&Ms that they're eating are not helping because it's just dumping more sugar into the bloodstream. It's not a sugar in the bloodstream problem. It's a sugar in the cell problem. And the part we're missing is the key. And no amount of M&Ms is going to help with that. but your body doesn't know that. Make sense? Good. So when we have a patient who is diabetic, we have a pancreas that isn't working, or the pancreas makes insulin, but it's the wrong kind of insulin. It's making car keys. We need house keys. Might be a key, but it's not going to open the cell. Okay. So we generally supplement with medication that are artificial keys. They can open the cell. And that's why we have to make sure with our diabetic patients that they're on a special diet and we keep them on that diet. And their diet is going to be based on their medications, because we're not producing insulin based on what we eat. We're externally introducing insulin or medication at a very specific dosage. So we need to make sure that we're eating the carbs that match that dose and not any more or any less. Good? Make sense? So when you have a diabetic patient and you notice they're not eating all of their food, who should you tell? If you have a diabetic patient and they're sneaking Hershey Kisses, who should you tell? The nurse. That's right. Because the medication is not going to match the food intake. Now, if we have a lot of excess blood sugar, right? So we ate these carbs, they weren't able to get it, the sugar wasn't able to get into the cell. That sugar stays in the bloodstream. Now, a certain portion of it is going to get packaged up and stored in our fat cells. It's actually what happens. When you eat too many carbs, your body packages it up, puts it in a little box, tapes the box shut, and shoves it into a storage unit. Now, over time, those storage units get all full, and we can't really make any more. We're like all full. So that sugar just stays in the bloodstream then. Doesn't have anywhere to go. It just stays there. We can't excrete it. It just stays there. So it circulates round and round and round and round and round and round and round. And as we eat, we put more in, round and round and round and round and round and round and round. So eventually we end up with a lot of sugar in our blood and nowhere for it to go. Oh, that creates a problem. Because sugar is a crystal. Kind of like this. Do you see how this has all kinds of sharp, jagged edges? This is what blood sugar looks like in your bloodstream. Lots of sharp, jagged edges. Now, these sugar molecules are heavy. So they're not just going to spin around your bloodstream. They're going to settle on the inside of your arteries. Now, when that happens, we end up with a problem. This is a nice, healthy artery. This is what you're born with. This is, man, I wish mine still looked like this. This is a really nice, clean pipe, right? Blood can get through it. Everything can get through it. There's no stoppages. There's no slowdowns. Everything just moves nicely. But over time, your arteries start to build up some gunk. And in our teens and 20s, especially with our American diet, we end up with something like this. Now, it's barely noticeable. Barely noticeable. But if you look close, the inside diameter here is smaller than this one. That's not much, but it has an effect. Not a huge one, but it starts to have an effect. Now, if we don't fix things here and we let this go on, we end up with all of these sugar molecules adhering to the inside of these arteries. And because they're sharp, jagged crystals, they catch all of the cholesterol going by. Cholesterol looks like pizza cheese in your arteries. So it catches all this pizza cheese and it binds it all up. And you end up with this gunk on the inside. Make sense? Good? I mean, not good, but do you understand? Okay, so the other thing it does, because these are sharp, it's going to, bless you, shred cells and platelets. So we're going to shred red blood cells, which carries oxygen. Your patients might get a little winded. It's going to shred white blood cells, which are your immune system. So your patients might have trouble healing or might be more at risk. It's going to capture platelets, which means your patient may not be able to stop bleeding as effectively. So this goopy mess, it's going to have some problems. Now, what's even worse than all of that, and that's bad enough, isn't it? That's bad enough. But what's even worse than all of that is there's a physics principle at play here. Whenever blood slows down or stops, it tends to clot. Right? This is how we stop bleeding if we cut ourselves. It's a good thing. It's not a good thing in a narrow opening, though, because this blood is going to slow down. And if this goes on too long, we end up with this situation where the blood is so restricted and having such a hard time getting through that artery, it has slowed down enough that it clots. Now, when this happens in the heart, the vessels that feed the heart muscle, we call it a heart attack. When it happens in the small vessels of the brain, we call it a stroke. When it happens in the small vessels of the kidneys, we call that end-stage renal disease. And when it happens in the small vessels of the eyes, we call it retinopathy. This is not good. So when we have a patient who is diabetic, they are at risk of a lot of things. Now, there's certain places in the body that this is going to have a bigger impact. Now, small vessels are definitely on the chopping block here. So small vessels in the kidneys or the heart or the brain or the eyes, they're at risk. But we also, on planet Earth, have gravity. Gravity pulls heavy things down. Well, sugar is a heavy molecule, so it's going to pull sugar down. What's the lowest part of my upper body? My hands. What's the lowest part of my lower body? Feet. So these effects are going to be concentrated in the hands and the feet. Hand care, foot care. That's why we do them. Good? Make sense? Good. So like I said, this wasn't a real in-depth understanding of diabetes, but I need you to understand how it relates to you. Okay. Now there is something you can do to help your patients. Every cell has a little tiny back door, not as effective as the big front door, little tiny back door. But if we can get that back door open, we can let some sugar into the cells. At least they're not starving anymore, and there's not as much sugar in the bloodstream then, right? So that door isn't opened with insulin. It's opened with protein. So when we have a patient who is having those cravings because their cells are dying, very valid craving, but if they're having a craving, if we can get them to eat some protein along with those carbs, it can help reduce the glycemic index, the effect of that blood sugar on the patient, or the effect of that sugar on the patient's blood sugar levels. So if they're, I need something sweet, we can apples and cheese, half a peanut butter sandwich, tuna fish and crackers, right? So we're pairing that protein with that carb, because the carb is going to help with that immediate craving. And that protein is going to open up a back door to let some of that sugar slip in and feed those cells. Okay. So a little tip for our diabetic friends. So we tend to have more effects in the hands and the feet of our diabetic patients, but there's another step to this that's more problematic for our patients, right? So far we talked about the buildup inside arteries, but this sugar actually builds up on the outside of nerves as well. Now, this actually looks like a power line in the winter up north. Have you ever seen a power line? I'm from Florida, but I hear this happens, right? You get ice on the power lines, right? And if it's bad enough, you end up with a brownout, right? Loss of power. Okay, that's what happens in the nervous system as well. These are the nerves that go through your body. And if you get a buildup of sugar, particularly in the lower parts of your body, you get a buildup of sugar on that nerve. What happens is the signals from that point can't make it up to your brain. So you can step on a thumbtack, your foot knows the thumbtack is there, and you, if you stepped on the thumbtack, would jump up and down, go ow, 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 and pull it out, right? Your patient can step on a thumbtack and the foot knows it's there, but can't get the signal to the brain, so the rest of the body has no idea, and that thumbtack stays. They lose the ability to feel or interpret that feeling, and that can end up with serious injuries that go unrecognized. This is one of the reasons that we do foot care on our patients, is to look at the foot. Make sense? Good. Now, diabetic patients will describe this as a pins and needles feeling, or ants crawling on their legs. And that's because that's telling us that the nerve, the line, because we're all hardwired, the line going from their feet up to their brain is corroded. It's all full of gunk, and the signals aren't making it through. So, yeah.
So their hands and feet are going to feel like pins and
Sometimes it's just the feet. Sometimes it's both. Every patient's a little bit different. But those are the two most common places that they're going to feel it, yeah. And it all has to do with gravity.
Isn't that a part of neuropathy?
That's what it's called, is neuropathy. That is the term for it, neuropathy. Okay, good. All right, so because of this risk of injury, right, they can have an injury and not know that they have it because of this neuropathy. We want to make sure that all patients are wearing shoes when they walk. We don't want them to step on a sharp object and get injured, because we may not even realize an injury exists. So anytime your patient is walking, they should have on shoes. Slipper socks are not enough. Now, if you've ever been a patient at a hospital, this is standard issue. They give you a hospital gown and a set of slipper socks. We get so excited about those things. We want to take them home, right? We think they're like a fashion accessory or something. I don't know what people's obsession is with slipper socks, but we like them. So here's the problem with them. They don't do a great job preventing slips, because they always spin around. There's no heel to them. So they don't do what they're supposed to do. And they're a huge infection control risk that you didn't even realize. If you were ever a patient in a hospital, you wore those slipper socks. You got out of bed and you walked to the bathroom. You did what you needed to do in the bathroom. And then you walked back to the bed and you got into the bed with those same slipper socks on. What got into bed with you? Everything. Now, if you had an incision, that's the perfect warm, dark, moist location for pathogens to invade and set up shop. Now, you're, twisting and turning and rolling and spinning all over that bed. Those pathogens are able to make their way up to an incision, lickety split, no problem. So when you wear slipper socks outside of the bed and you walk around with them and get back into bed with them, you are importing the very pathogens we're trying to protect our patients from. When your patient is out of bed, they should have on shoes. Slipper socks are not enough. But wait, Miss Patty, wait, what if they don't have shoes? Who do we tell? The nurse. Yeah, the nurse has all kinds of resources. We can pick up the phone, call the facility they came from. Hey, send Georgia shoes. We can call the family. Hey, does Martha have any shoes? If the patient is homeless and has no shoes, we have social workers. Hey, get this guy some shoes. We've got ways to solve the problem. We just have to know there is a problem. But in the meantime, because that's going to take some time to get some shoes, in the meantime, we should be changing those slipper socks after they walk in them before they get back into bed, or putting a second pair on while they're walking that we remove. But we need to be protecting those feet. Good? Make sense? Do you guys understand why? My rule of thumb is if I would not let a child walk barefoot on that floor, I should not let an adult walk barefoot on that floor. Right? There should not be two separate standards here. If it's not safe for a child, it's not safe for an adult. Good? If you've ever been to this hospital right up the road, we're not going to say the name, there is a Subway in the lobby. And every time I go to that hospital, there's always a patient standing in line at the Subway in that lobby in slipper socks, which means that they walked from their room, down the hallway, into the elevator, down the hallway, to a food establishment, got their food, walked all the way back, and then got into bed with those slipper socks and their foot long. What else got into bed with them? Everything. Yep. Hope the foot long was worth it. Right? All right. So when we're using a gait belt to help our patients stand, we're going to put it on around the waist. Gait belts go around the patient's waist, not yours, the patient's. I'm going to demonstrate on me just because I'm up here. So around the patient's waist, and it does not matter whether the buckle faces this way or the buckle faces this way, nobody cares. What matters is the tag goes inside like every other article of clothing. This goes around the patient's waist, and you want to make sure when you put it around the waist that it's flat, that it's not twisted. Okay, it's got to be flat. When you get it around the patient's waist, you put the free end through the first guard by the alligator teeth, and then you pull to tighten. Don't pull this way. It won't tighten. You have to pull this way. And we want to make sure it's snug enough that when we go to lift this patient, it doesn't come up underneath their breasts or underneath their arms and they don't slide out. So it's got to stay in place. The way to figure that out is to 4 fingers flat between the belt and the patient, just like this. This, way too loose. This, a little too tight. Okay. So we just want to be able to fit 4 fingers between the belt and the patient. Then we take the free end through the second guard, and that locks it in. Now this tail hanging down on some of you is going to be very long because you're thin. This tail, if it's in your way, just tuck it into the belt to get it out of the way. That's all we're going to do. Now when it's time to take the belt off, we remove it from the second guard. But this time, instead of pulling the tail, we're going to pull the buckle, slide the buckle along the belt. Okay, so belt to tighten, buckle to loosen. Good. Now, when we go to remove this, do not pull it. Listen close. You guys hear that? That's going to take skin with it. Don't pull it against the skin. That'll cause a burn. We're going to loop up and over, holding, don't let it bang your patient's head, right? So hold on to this, loop it up and over, or you can take your hands behind and get it that way, but don't pull it against the skin. Good? Good? Okay. Patient's feet must be flat on the floor before we stand them. That just makes sense. If their feet are not flat on the floor, if they're on their tiptoes, you will pull them off balance. This is a me problem. I have short legs. When I sit in this chair, my feet are not flat on the floor. My heels are always up, always, because I can't put them, my legs just aren't long. I prayed for legs. I got hips instead. Be more specific in your prayers, okay? I got width, not length. My feet just don't hit the floor. So for me, I have to scoot forward so my feet are flat on the floor. You got to make sure that your patient's feet are flat on the floor. especially if you're working with a confused patient. We're going to count to 3 before we lift. 1, 2, 3, and then we're going to lift. And then once we lift them, we're going to ask, are you dizzy? If they're dizzy, sit them back down. We're not going anywhere. This is where we want to know. Don't wait until you're way over there. If your patient is dizzy way over there, you're out of options. You're going to have to lower them to the floor because a patient sitting on the floor can't fall on the floor. Lower. Don't rush them back to that. They're not tolerating a slow walk. You think they're going to tolerate a rush back to the chair? Not a chance. If they're dizzy over there, we're sitting on the floor. And I'm going to call for a nurse, somebody to come help me. We're not rushing them anywhere. Okay? Got it? But I want to know here. So I stand the patient up. Are you dizzy? We good? We good to go? Everything good? If they say no, we're sitting. We're not going nowhere. Okay. After we take a walk, remember we're only going 10 steps. So it's 5 steps in one direction, 5 steps back. This is why they give us 5 minutes to do this skill. It's not hard. When we get back to the chair, we back them up so their legs hit the back of the chair. They have to know it's there. Don't ask a patient to trust you. They have to know that chair is there. Once they can feel the chair, we're going to help them sit. Now, body mechanics is important here. We're going to stand at an oblique angle, 1 foot in front of their feet, 1 foot parallel to the chair. This is how we're going to stand. We're bending at the knees, not the waist. Bend at the knees. We're going to hold the gait belt around the sides or around the back. And on the count of 3, we're going to lift. 1, 2, 3. That stands the patient up with stability. If you stand in front of somebody and you pull them up toward you, physics, every action has an equal and opposite reaction. You pull 150 pounds towards you, your body is going to go 150 pounds in the other direction. How long do you think your back is going to hold up? Not long. Stand at an oblique angle at the corner of your patient. That gives you stability. Remove any obstacles before you stand the patient up to walk. Just scan your environment. Make sure there's nothing in your way. All right. So we're going to apply our patient's gait belt over their clothing. Why that has to be specified, I don't know. Don't put gait belts on bare skin. Over the clothing. You're going to hold the gait belt on the sides or around the back as you lift. And their hands should be on your shoulders. So you see, do you see this? How her hands are just resting on my shoulders? If you don't do that, when you lift a patient, this is what they're going to look like. See how their body is trending backwards? This is unstable. This is likely to cause a fall. If her hands were just resting, not around your neck, not holding on, just resting, it moves the patient as a unit. So it keeps that imbalance from occurring. We're going to let our patient lead. We're going to walk slightly behind and to one side, and our focus should be 100% on that patient, not your cell phone, not the coworker you're talking to. Your patient needs to be your focus. And I can tell when they're not your focus because I hear this. I don't know, we were just walking. Next thing I know, she's on the floor. I don't know what happened. Your patient gives you signs that something is wrong. They don't just walk along, I'm good, I'm good. They don't do that. They get pale, they get sweaty, they slow down, they put a hand out, they start to wobble, they put a hand here or here, they start to buckle. They give you tons of warning that they're about to go down. You missed the signs because you weren't focused on that patient. Walking is dangerous. If you're not paying attention to your patient, something bad is going to happen. Monitor them throughout the skill. So as you're walking, you're doing okay. And then we're going to use that same body mechanics to lower them back to the chair. You notice I'm bending at the knees, not at the waist. Keep your back straight. We'll remove that gait belt by looping it or gathering it with both hands, but not by sliding it. Make sure your patient is seated properly in the chair. And then we're going to do our closing. Questions on that? Let's use these to check off this. We're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. Your patient is a live student, fully clothed, holding on to all of their own body fluids. Do you need gloves for this? No. Your mileage may vary depending on your patients wherever you're working. We're going to follow those shoe rules that we just learned. Make sure that they have shoes on. We're going to put our gait belt on correctly. We're going to count to 3 before lifting, making sure their feet are flat on the floor first. Ask them if they're dizzy when we stand and making sure they can feel that chair. We're going to use our gait belt steps we just went over and then do our closing. We're going to put all of that together to get 100% on this skill. And remember, this care plan is only for this guy. It's not for these other people. These other people have different care plans based on their specific needs.
As a CNA, saying wherever we're working, do we get a lot of this because so many people have to have hip replacements and fingers broken?
I can't generalize like that because every patient is individual. We aren't using gait belts as much for physical deficiencies, okay, like hip replacements. That's more physical therapy. We use gait belts more for energy conservation to give them a little bit of our strength. So as CNAs, we use gait belts for a different purpose. So your setting is kind of irrelevant. It depends on that particular patient. Now, there are some settings that don't let you use gait belts at all because a lot of aides, CNAs or resident aides use gait belts to tie patients to various places, into chairs, into wheelchairs, onto beds, to keep them from moving. That effectively becomes a restraint, which we are not allowed to use. So because administrators can't trust you to do the right things, a lot of times they restrict gait belts. They restrict your tools because they can't trust your ethics. I'm not in favor of that, but we're not going to get me started there. All right, so let me show you this video. It takes 3 minutes. Remember, we have 5.
Hello.
Good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Do you feel like going for a little walk?
Yes, that'd be lovely.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to clear the walkway of obstructions. Close the privacy curtain and wash my hands. Now that I have clean hands, I'll get the gait belt. Mr. Jones, I see you have non-skid footwear on. Does it fit appropriately?
Yes.
Very good. This gait belt I'm going to put around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk. Is that okay?
Yes.
Okay, I'm just going to slide this around your back. Okay, and lift your arms and relax. We're going to put the free end through the first guard by the alligator teeth and pull it so that it tightens the belt. We want the belt to be snug. We want to only be able to fit 4 fingers between the belt and the patient, and then we'll lock it in place by putting the free end through the second guard. And then we'll place the free end through the top just to hold it in place. Okay, Mr. Jones, your feet are together. In just a few moments, I'm going to have you place your hands on my shoulders And I'm going to place my hands around your back. And on the count of 3, we're going to stand together. Okay?
Okay.
So I'll put one foot in front of your feet to keep them from sliding out. One foot beside the chair to keep me at an oblique angle. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Thank you very much. Are you dizzy at all?
No.
Okay. So at your pace, when you're ready, I'm going to have you lead and we're going to walk to the wall. I'll walk slightly behind and to one side, watching the patient. Okay, and go ahead and turn. And then we're going to walk back to the chair. Are you dizzy at all?
No.
Very good. So when you get to the chair, if you can turn around for me and back up so that your knees hit the chair, come my way just a little bit. And on the count of 3, can you feel the chair behind you?
Yes.
You're going to place your hands on my shoulders. Go ahead. I'm going to put one foot in front and one foot beside. And on the count of 3, we're going to lower. Ready?
Yes.
1, 2, 3. Being careful to bend at the knees and not the back. I'll remove the gait belt by taking it out of the second guard and then removing it from the first guard. We're going to remove it by looping it over the patient, being careful not to let any part hit the patient. And are you comfortable?
Yes.
Could you slide back so that your hips are against the back of the chair? Very good. I'm just going to go put the gait belt away. Are you comfortable, Mr. Jones?
Yes, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your environment is clean. I'm going to hand you your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections that need to be made, and then tell the evaluator my skill is done. All right, any questions on Ambulate?
Not necessarily for Ambulate, but at the end of every single skill, you always want to make sure the cola is in the hand or can it be set on the belt, like beside them?
Most skills, the checkpoint is call light in or near the hand. So for most skills, just laying it on the bed within reach is perfectly okay. There are a few exceptions to that, however. One of them is dressing a resident with a weak arm and sideline position. It must be in the hand. And I'm pretty good about highlighting that. You know, that it's got to be in that bottom hand or in the stronger hand. The rest of them, just near the hand is fine. All right, any other questions? Partial bed bath, page 126. This is a long skill. And there's not much to teach you. So I'm going to go through this pretty quick because this is all a review of what we've already learned. So everything I'm about to say is pretty quick with the exception of learning how to use that washcloth. That we're going to spend some time on. And I'm trying to leave enough time for you to see the whole video at the end of this. All right, here we go. So if you look down the side there, you can see all the principles involved. They're all spelled out for us here. We know all of them. We know all of them. Nothing new to learn here other than one checkpoint on washing rules that we haven't gotten to yet. That's the only new thing that we're going to learn. But man, look at all those steps. Look, this is a long skill. There's a lot of steps here, but none of them are hard. This is a mannequin skill, and they give you 19 minutes to do this one. If we go to page 127 at the top of the page, you're going to see the care plan. That care plan we're going to look at in detail in just a minute. Supplies are at the bottom, and there's a lot of supplies. So again, if you're not making flashcards, you should be. Let's look at this care plan. Long care plan, guys. Care plan says give the resident a partial bed bath. Let's stop there. Time out. That word partial means not full. It doesn't mean anything more than that. It just means not head to toe. If it's a partial bed bath, it's got to tell you what parts it wants you to wash. Make sense? That's why this care plan is so long. So the care plan is going to tell us exactly what parts we should be washing. It tells us, let me time back in, it says, and a back rub. We are not massage therapists. This is a very brief back rub. We're not trying to deep tissue anything. This is just basically to promote circulation and make the patient feel a little better. Now it's going to tell us exactly what parts we need to wash. Wash the patient's or wash the resident's face, neck, chest, abdomen, back, and one arm and hand. Now, I hear the wheels spinning. What if the patient has two? What does care plan say? One. So if the patient has two arms, how many are we washing? One. We don't care about the other one. Now, this care plan doesn't tell you right or left. That's your choice. You can, whichever one. In a clinical setting, if it only has one arm, it's going to tell you which one. Okay. It'll be clear. But for the test, they're just asking you, are you going to follow the care plan? That's what this is. That's what this whole skill is. Are you going to follow the care plan? Now, we can shortcut this a little bit, right? Because that's a whole lot. That's a lot. That's a lot to remember. Face to waist, front and back. One arm and hand. Face to waist, front and back, one arm and hand. That's what this care plan is asking us to do. So shortening it a little bit makes it easier to remember what you're supposed to be washing. Good? Good? Okay. So let's provide a brief back rub with lotion. Dress the resident in a hospital gown. Patient is lying on back and center of bed and can roll as directed, but is too weak to assist with bathing. So they can roll. So you can ask her, hey, can you turn on your side? But she's a mannequin. She's not going to. So you are going to have to turn her. And the problem is, if this were a real person skill, if you were the patient for this, you could roll on your side and stay there because humans can stay on their side. Anybody ever play with a Barbie doll? They do not stay on their side. So for this skill, the evaluator is going to reach over and hold that mannequin in place when you turn her on her side. Okay. And that's just because they know mannequins don't stay on their sides. You won't have to ask. They'll do it. All right, so here are all of our principles. These are all the things that we know, but we have to fill in the blank on one of our washing rules, and that is, we're going to review. Sorry, let's review. Basins are no soap zones. We use a paper towel to turn our water on. We check it. We have our patient check it. Whatever we wash, we rinse. Whatever we rinse, we dry. Change the water if it gets cold or soapy. Don't get your surface wet. Warm your lotion up and wipe it off after, right? So we know all those rules. So this last one, we're going to kind of fill in a gap there. And this is, we use the leaves method for wet body openings. Now, if you remember way back to class 2, and I know that was a very long time ago, way back to class 2, we learned about the chain of infection, and we learned about wet body openings, and we learned that wet body openings can let things out and let things in. So we have to be very concerned when we're working around wet body openings, and that's what this process is designed to address. Okay. So eyes, nose, mouth, genitals, anal area, wounds, rashes, sores, and incisions are all wet body openings. So if we're washing any of those things, we're going to use a very special cleaning method called the leaves method. So what this is is we take a regular washcloth. I've passed them out for you. This is just a square. You probably have this in a linen closet at home. Normally, we fold it in half, and then we fold it in half again, and I end up with a small square. And all of you have this in front of you, a small square. But instead of looking at it as a square, I want you to look at it as a diamond. And we're going to put this diamond in our hand with the free ends facing up. So see how these are the free ends, the free corners facing up. We're going to tuck one side, one corner in between our pinky and our ring finger like this. We're going to tuck the other corner in between our thumb and index finger like this. Good. Then I can wash a wet body opening. And now I've got body goo on here. I don't want to put that body goo anywhere else. So I'm going to fold that over, which traps the contamination underneath and gives me a new cleaning surface. I can wipe something, fold that over, and give me a new cleaning surface. I can wipe something else, fold that over, giving me another new cleaning surface. And I can even wipe something else and fold that over and give me a new cleaning surface. So I have 5 independent cleaning surfaces with one washcloth using the leaves method. Isn't that cool?
It feels a little hard when you have little hands.
It is. It'll take you a little bit of time to get used to it. Yep. Yep. Okay. So this graphic shows you what I just showed you. So holding it up with your free leaves at the top, you can wipe something, fold that first leaf over, and then you've got a new one. You can wipe something, fold that leaf over, giving you a new one to work with. You can wipe something, fold that leaf over, giving you a new one to work with. And then you can wipe something and fold that leaf over, and you can even use the back side if you need to. Good? I'm going to put this into practice with you in just a moment. So these are all the principles that we're going to use for this particular skill. Now let's learn our skill-specific steps. And we're going to put this leaves method to use on this in just a minute. So we're going to follow the care plan, which is going to be graded on the checklist. We have to follow the care plan. So the first thing that we're going to wash is our face. Face first, no soap on the face. Soap stings the eyes, it dries the skin, no soap on the face, just water. So I'm going to take my washcloth, positioned in the leaves method, and I'm going to wash from inner to outer corner on the first eye and then fold that over. I'm going to wash inner to outer corner on the second eye and then fold that over. And now the third leaf, I'm going to wash the face. And then I'm going to fold that over, and I'm going to wash the nose last because boogers. Now, this has body fluids on it, so I'm going to set it aside on my barrier, which is not on my table. We're going to pretend on my barrier, okay? And then I'm going to dry because whatever I rinse, I dry. So I'm going to take a towel and dry. Good? Now, for partial bed bath, remember I said face to waist, front and back, one arm and hand, right? Remember that? Face to waist. So the only area that I'm cleaning with wet body openings is here. There's no wet body openings here. So I don't need that leaves method for the torso or the back. I just need it for the face because this is where my wet body openings are. Good? Make sense? So the first washcloth, face first, no soap. First washcloth, we wring out, just water. We're going to wash the eyes, the face, the nose last. Set that aside, dry. I'm going to get some washcloth 2, wring it out really well. And I'm going to apply some soap. And then I'm going to just use that one washcloth and wash all this. All the front.
And the arm.
Yep, and the arm. And armpit last because ew. Okay. Good. Good. Then I'm going to turn the page. I'm going to rinse because whatever I wash, I rinse. Then I'm going to dry. Then I'm going to dress and turn the patient over. And I'm going to wash the back. I'm going to rinse the back. I'm going to dry the back. And I'm going to give a little back rub with lotion. That's the skill. But the thing that we have to learn here is that leaves method. That's the new thing.
How do you rinse the back? Because like for the hand and the foot, you would just put it in the.
All right, we're going to get there. Okay. All right. So remember, we're going to use that leaves method on wet body openings. And for us, for this skill, that's the face. Now, we are going to use the same method with pericare on Wednesday. Okay. So this isn't the last time you're going to see it. We'll also use it for catheter care next Monday. So you're going to see this method quite a bit. It's not the last skill we're going to use it. It's just the first. Make sure you're controlling that washcloth. No drippy wet washcloths. You don't want it waving around. That's where that leaves method, that holding that washcloth helps. So wring your washcloths out thoroughly. We're going to wash the neck, the upper chest, down to the waist, up the side, down one arm. We're going to lift from below with a flat palm. We've heard that before. And we're going to wash up and armpit last. We'll set that washcloth aside. Then we're going to get our rinsing washcloth and wring it out. Okay, we don't return washing washcloths, anything with body fluids or soap, to the basin. We're going to take our rinsing washcloth, rinse it out really well, or wring it out really well, and we're going to rinse the neck, the upper chest, the abdomen, down to the belly button, up the side, down the arm, and up the back of the arm, and the same way we washed. Now, that rinsing washcloth, we didn't put soap on it, and it was not around body fluids. You can reuse that washcloth. You don't have to. That's right, for the back. You don't have to, but here's the deal. It'd be easier if I just told you get 5 washcloths, use one for every body part, one to wash, one to rinse. It'd be easier, right? And that's fine. You can do that. Test allows you to use 5 washcloths. I don't teach it to you that way because out there in clinical world, you are never going to have enough supplies. You're just not. You're not. Unfortunately, CNAs, I don't know why you do this, CNAs out there, but you will go in, you will gather all of your supplies that you're going to need for your patients, for your shift, and you are going to hoard them. So the next person that comes along isn't going to have enough supplies. That is a very common problem. Do not do that to your coworkers, guys. Don't do that. They stuff them everywhere. Everywhere. Which means they're not clean. There's a whole nother principle, but we're not going to get into that. What I'm telling you is I am teaching you a method you can use when you don't have enough supplies. You can do this in 4 washcloths. You can reuse a rinsing washcloth as long as there are no body fluids on it. Make sense? Rinsing washcloths can be reused. So that's why I'm showing you how to do this with 4. But if you want 5 for the test, go for it. They're not going to restrict you.
So they making sure we have gloves on for the baby?
Right, because we're around wet body openings, right? And that is a reason to wear gloves.
Now we're learning this along with the wet washcloth
And gloves, right. Need some practice. Need some practice. So whatever we wash, we rinse. Whatever we rinse, we dry. So we've turned the patient, after we wash the front, rinse the front, dry the front, we're going to put the gown on. I'll tell you about that in a minute. And then we're going to turn the patient over, wash the back, rinse the back, dry the back. And then we're going to give them a little back rub. This is just 3 passes from waist to shoulders, up, small circles, 2, 3, I'm done. Okay. Brief back rub. All right. Let's talk about this gown. Some of you are going to want to wait until the patient is completely dry, clean front and back to change that gown. That's fine if you want to do it that way. But you have to turn them twice. You have to turn them twice. I don't like that method because I'm all about efficiency. I got a lot to do, very little time to do it, and I want my break. I don't want to give up my break. So I'm all about efficiency. So I wash the front, rinse the front, dry the front, dress the front. Turn the patient over, wash the back, rinse the back, dry the back, give a back rub, tie the gown. Quick, easy, effective, and I get my break. Okay, good. But the test isn't grading when you change that. If you want to clean the front, clean the back, change the gown, you can do it that way if you want. They're covered with a privacy blanket. Yeah. Yeah.
So you'll just put the gown on after you clean the front side?
Right.
Okay.
Right. Wash the front, rinse the front, dry the front, dress the front.
Okay.
Yeah. I just don't tie the back of the gown until I'm done with the back. It does make it a lot easier if you do it that way. But if you forget on the test and you turn the patient over and you wash their back and then you realize, oh, I don't have a gown on, you can, it's fine. Put them back on their back, put the gown on, turn them over, tie the gown. That's fine. You can do it that way, but it's more work on you and it's more time. You're covered with a privacy blanket. If the privacy blanket slips, it's okay. They're not grading you that harshly. Yeah. So bathing, there's a certain expectation of exposure with bathing. We're going to try to limit that as much as we can using the privacy blanket. We try to limit it. Now, during the test, though, this is a topic we have to talk about because during the test, the evaluators have to see what you're doing. If they're covered with a privacy blanket, they can't see what you're doing under that blanket. So the evaluators are going to tell you at some point, move that privacy blanket so we can see. So you're just going to fold it down and that way they can see what you're doing under there and they can grade your technique. But don't fold that blanket down until they tell you to, because you need that privacy check mark. Okay. Good. Good. All right. So we're going to use all of those steps to check this off. We're going to follow that care plan, which tells us exactly what to wash. We're going to do our opening. We will wear gloves for this because it's body fluids. We're going to use a barrier, privacy blanket, and linen rules. We're going to keep our patient safely in the middle of the bed at all times. We're going to use our washing rules and clean our basin the same way we clean it at the end of every cleaning skill. And we're going to do, follow our partial bed bath steps and then do our closing. This care plan is only for this patient, not these guys over here. They have different care plans. One of them gets a shower. One of them bathes themselves. The other one, I don't know, does something else. This care plan is only for this patient. Okay. Jake, go ahead and show this video. And while the video is playing, Jake's going to pass out your review sheets. I've got it written down. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about 1/4 of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. Placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and we'll untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Miss Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye. Fold that leaf over. And with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over, and with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it. And I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet. And then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breast, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluator will ask you to move the blanket if they would like to see. I'm going to go ahead and remove the blanket now so that you can see what I'm going to do. So we're going to move the blanket down. And I'm going to start again to show you how to clean the patient. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breast to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that, so we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place. Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me, and then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place During your cleaning, during the test, live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside, and we'll get our rinsing washcloth. So we'll wring that out, and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside, and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table, and then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. Rinse the basin, and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with the paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage, adjust the sheet for neatness and appearance. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done. Okay. You had a question?
I have a couple.
Yeah.
So at that point, with all those procedures and you just said, I'm gonna go through my care plan, like you put everything away, took your gloves off, did it, and now you're reading back over and say, oh my God, I forgot to give a back rub. Do we just say, oh, I forgot to do a back rub, or do we have to go back and actually
Okay.
do the back rub?
You can review that care plan at any time during the skill. I review it at the end because I know these care plans forwards and backwards.
Right.
If you want to stop in the middle of the skill and review that care plan to make sure, that's perfectly okay.
I'm saying, like, what if we felt really confident, we did everything, and then and we decided at the end, and then we're like, oh my God, I forgot. the
Yeah,
back rub.
You would say, correction, I forgot the back rub, and they're going to tell you, we need to see that, please. Yeah. And depending on the evaluator, they probably won't make you put a privacy blanket on and all of that. They just want to see the actual back rub part. Depends on the evaluator, but yeah. Other questions? You said you had several.
I had one more too, is watching it and thinking about myself, and she has the privacy blanket on, goes to completely take off the gown, put it in the dirty linens, and then go back.
That's fine. You can do that.
Okay.
You can do that. Yep. Any others?
Everybody wants to go home.
Okay. Thank you guys for hanging out with me. Game show is tomorrow. Don't forget. Jake passed out your class review sheets, and you have one chapter of homework tonight. That's chapter 7, which is another skills chapter. Read the paragraphs in between. If anybody's not getting your wrap-up emails, please let Jake know, and he can make sure to address that. And if you need the information for CPR, you can take a screenshot of this. It's also on your day 1 handout, the blue sheet. Okay. All right. Until next time, we'll be back on Wednesday for class 6. Game show tomorrow. Until next time, happy caregiving. Bye.
I have another question.
Yes.
So I don't know